you all for the Synergy 14 webinar on the topic early detection, informed decisions, clarity for a healthy start, the role of prenatal genetic diagnosis. Before starting the webinar, we will have a prayer.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
I would like to introduce the convener of the webinar, Dr. Monica Singh. Dr. Monica Singh is President-elect of Bhopal Obstetrics and Gynec Society. She is founder president of ISOAP chapter of Bhopal. She is national executive member of ISA. She is joint secretary, joint treasurer of MPIAG and coordinator of Foxy Infertility Committee. Now I would like to hand over the webinar to Dr. Monica Singh.
A very big thank you to you, Dr. Vishal, for that generous introduction. And we are gladly in the third year of our academic series of webinars. We started with Perfection series with ISAR. We went on to Symbiosis. We had Embryology Excellence with ISAR. And ultimately, we came down to Synergy, which was an open platform for all organizations and all societies who want to collaborate and want to present their work. Of course, I've got a wonderful team of coordinators. The team has increased over the past few months because we had a lot of work to do. So everybody contributes brilliantly. And today we have the Synergy Academic Club episode number 14 coming in front of you with two great episodes on prenatal genetics. Since this topic was too vast to be covered in one webinar, that is why we decided to split this whole concept into two episodes. The episode 14 will be telling you about how to do early detection, how to make informed decisions, how should we be clear about diagnosis for a healthy start to a pregnancy or preconception, and what role does prenatal genetic diagnosis counseling all play in your clinical practice. So today, 14th May, Wednesday, 2025, we gather here for the next 2 to 3 hours for some brilliant deliberations. And I'm very happy to inform that our webinar has been granted 3 ICOG points by the Indian College of Obstetricians and Gynecologists, the academic wing of Foxy. So today I am very happy to present before you the program. Before I come to the guests, I would just like to give you an overview of the program which we are going to highlight today. We have got 2 talks and a panel discussion. The panel discussion, we tried to do away in a couple of episodes, but I feel that the maximum involvement of participants is when the panel discussion takes place and we get so many inputs. So we thought that we'll continue with panel discussion. And as you can see, our number of panelists has gone up to 12, 14, and even 16. So the first talk, the speaker is very sought after, Dr. Ratna Duapuri from Sir Gangaram Hospital, New Delhi, who will be telling us about genetic counseling in prenatal diagnosis and the current status of NIPT. The next talk is by Dr. Divya Singh, who is a brilliant radiologist, alumnus of PGI Chandigarh, who will be telling us how ultrasound can act as a window into prenatal genetics, because the tests are not tangible, but ultrasound is something which you see, so you should be all perfect with your ultrasound techniques and diagnosis. Lastly, we have got a panel discussion dealing with challenges in genetic diagnosis, a rendezvous with experts, moderated by Dr. Asha Jain, who is current chairperson of Foxy Food, Drugs and Medico-Surgical Equipment Committee. And we have a galaxy of panelists over there. So coming to the formalities of the program, we welcome amongst us our chief guest for the evening, Dr. Parag Biniwale, chairperson ICOG. Sir has joined, Dr. Shweta?
Yes, ma'am.
Monica, I'm here. I joined before you. But
Sir was the first person to join.
Oh, I did not see in the panel, so I thought, I'm sorry, sir. But sir, this meeting has been given, charge chance because of your presence. So, sir is a very, very respected senior gynecologist from the great city of Pune. He is at present the chairperson of ICOG and a very renowned PG teacher and unit head at Kamla Nehru Hospital. Besides being chairing the biggest organization, ICOG of Obs and Gynae, where as far as academics is concerned, Sir was also the president of the Menopause Society of Pune from 2018 to 22, president of Pune OBGY Society 22 to 23, the national website editor of Foxy 2011 to 2017, peer reviewer of the Journal of OBGY of India Jogi 2011 to 17, and the chairperson of the Young Talent Promotion Committee of Foxy, which did wonderfully under his chairpersonship 2008 to 2010. He is an avid academician, the co-editor of these three books, Gynecological Manual on Adolescent Girl and Young Women, Yearbook of OBGY 2019, and Exploring New Horizons of OBGYN. He has contributed several articles to books and journals, delivered orations, guest lectures in over 160 Foxy societies, the recipient of Dr. C.S. Dawn Prize at the 51st AICOG in New Delhi in 2008, and we recently attended a brilliant national ICOG conference in Pune under his chairpersonship. We welcome you, sir, to our program, and we would be very happy and delighted to listen to a few words from you, sir.
Thank you, Monica. Good evening, all. I bring greetings from ICOG, and it's indeed a pleasure to be part of Synergy program once again. I must compliment you because persistently you are doing these educational activities for last many, many years, and that is commendable. Indeed, a pleasure to share the virtual dais with Dr. Archana Dwivedi, the chairperson of Midlife Management Committee, and of course, all the seniors from Bhopal, Dr. Shashi Srivastav, Dr. Sarla Jain, Dr. Vaijayanti Kolekar, and Dr. Abha Jain. Of course, Dr. Randir is very much part and parcel of the team. I think he's a big support to Monica. Monica, first of all, thank you very much for asking me to join this program. And when I looked at the program, I found it was really very, very interesting. The concepts in genetics have really changed, and they have in fact helped us obstetricians in a big way. And then that has added a lot of value when we are managing complicated pregnancies. So I'm definitely looking forward to Dr. Ratnapuri. He was one of the best speakers in the country who will be talking about NIPT, because that is something which is coming up in a big way. And judicial use of this particular test is what is need of the hour. We shouldn't be doing it randomly. And I'm sure Dr. Ratna will throw a light on this. And the interesting panel discussion. I'm happy that you allotted 1.5 hours for panel discussion, because panel discussion has to go on and on because it generates a lot of interaction and some wonderful take-home messages. And I remember moderating one panel discussion with Dr. Manju Verma, one of the senior teachers from Allahabad, in one of the conferences, and we had a C-section panel for 1.5 hours. So it was amazing because there were such great inputs from all the participants. So I'm sure even today's panel discussion will give us some good take-home messages. So my best wishes for the program, and Monica, best wishes to you for all your future endeavors. Thank you once again for this opportunity. Monica, you need to unmute.
Thank you so much, Parag sir, for your gracious presence and your kind words. It's always a pleasure when you are there in person or virtually in our programs to give blessings to all of us. And we are honored to be under your chairpersonship in ICOG, and we hope the organization reaches greater height under your leadership, sir. Thank you so much, sir. And now I would like to welcome our guests of honor for the evening. We have three brilliant personalities, Dr. Archana Dwivedi, who is the chairperson, Midlife Management Committee of Foxy, and also a very big name in Indian Menopause Society scene. Again, immediate past president of Bhopal Menopause Society and a national chairperson, Dr. Shashi Srivastav ma'am, and Dr. Sarla Jain, a very active member of Bhopal Menopause Society, Bhopal Obs-Gynae Society, and a senior gynecologist from the city of Bhopal, Dr. Sarla Jain. Introducing Dr. Archana Dwivedi, she is a very, very dear friend. I can always call her up for any issues, any doubts, any problems I have, and she's always there. She has one.
Monica, that introduction was fantastic and most apt, I would say.
I would just like to just add, Dr. Archana, how important you are on the scene of OBGY in Baroda and now all over India. How beautifully you handle the Midlife Management Committee. In fact, in ICOG conference in Pune, when we went after meeting Parag sir, I met Archana and I was telling her, Archana, I have got a few issues, you know, the midlife problems. So she said, Monica, you must come and talk to me. But somehow we could not connect that time. So Archana, she always has time for friends and she's always lending a helping hand. Welcome you, Archana, and we would like to have a few words from you.
I think it's an honor to be a part of this continuous learning journey, Monica, whatever be the name, symbiosis, synergy, and everything. But you're doing a great job, as respected Parag sir has already said. And with ICOG coming in, I think it becomes more, important for us, all of us, as a training session and learning experience. And Vanda Vansal ma'am is here from Prayagraj. So I'm very happy to see you, ma'am. I'm in Prayagraj and Limbinai as well, with Dr. Shashi, with all the dignitaries over here. As sir already said, listening to Ratnapuri madam, Divya ma'am, and the panel itself by Dr. Asha Jain would be a real learning experience, and you have jotted it very nicely. Only thing is that it's a need of hour that we need to understand what we have to prescribe our patients and be updated. And actually, rationally, we are helping them to seek help where the congenital abnormalities can be reduced. Because more and more midlife pregnancies, I would say above 35 people are conceiving. So I think this program has got a very apt message for all of us. So not standing between the education part in this, thank you for making me a part. I think it will be a great learning experience for me as well. Thank you, Monica.
Thank you. We'll be honored if you could stay on and listen in the program.
Yeah, would be the-
Provide your inputs as well. So next, I would like to welcome and introduce our guest of honor, Dr. Shashi Srivastava ma'am. She is the immediate past president of Bhopal Menopause Society and recently has taken, her chair as the chairperson of I think the website committee of Indian Menopause Society and the Public Relations Committee. And she's very active in the scene of Menopause Society of Bhopal. In fact, we are very honored that under her leadership and Dr. Vijayanti Kolekar's leadership, we'll be hosting the National Conference of Indian Menopause Society in the month of February 2026. And I invite Dr. Archana, especially you have to come, and I invite all the friends from all over India to this conference to make it a grand success. Madam is the director of Sauram Nursing Home, a very reputed nursing home in Bhopal, as well as very active in the PCOS Society of India, FOXY, and her areas of interest are RPL, ultrasound, and PCOS. We welcome you, Shashi ma'am, and we would love to have a few words from you.
Thank you, Monica. Dear chairpersons and dignitaries, fellow professionals and respected audience, it is a true privilege to join you today for this insightful episode of Synergy Club, focusing on subject of immense importance, prenatal genetic diagnosis. In the evolving landscape of reproductive and fetal medicine, prenatal genetic diagnosis stand at the forefront of the precision care. It offers an unprecedented opportunity to detect and address genetic conditions at the earliest possible stage, allowing parents and practitioners to make informed and timely decisions. But with a great power comes a greater responsibilities. As healthcare providers, we are not just interpreters of service, we are also guardians of and empathy. We must ensure that such technologies are accessible, understandable, and always delivered with the compassion. I commend the Synergy Club for the organizing this much needed discussions. Interactives like these strengthen our collective resolve to advance knowledge, foster dialogue, and serve our patients better with science, sensitivity, and soul. Let this gathering be a reminder that every healthy birth begins with informed care, and our role in that journey is vital. So thank you once again for having me here. I wish the event great success. Thank you, Monica.
Thank you, Shashi ma'am. And I think the key word of your talk was informed consent. I think this is what we should start with. Our patient is nowadays a very, very important figure in front of us. Everything should be informed, which we'll be now listening to her, Madam herself as to how to do it. Next, I would like to invite Dr. Sarla Jain, our guest of honor for the evening. Dr. Sarla Jain is a very senior gynecologist from the city of Bhopal. She is regarded very highly amongst the fraternity of Bhopal Menopause Society and Bhopal OBGY Society. Last 4 decades of practice in Bhopal, alumnus of Gandhi Medical College, and has done CMS from Vienna, a life member of all important gynae organizations of the country, held the post of past secretary of Bhopal Menopause Society, and now the president of Menopause Society in 21-22. She organized the very successful West Zone IMS conference in Bhopal in 2019. We welcome you, Sarla ma'am. We'd like to have a few words from you, madam. I think madam was there. Shashi ma'am? She was there when we started.
Showing here, but definitely we would like to hear from ma'am. And let me tell you that 2019 I have witnessed, it was so beautifully organized. And IMS remains the first family. So I think Bhopal is going to host in February. Shashi ma'am, we are looking forward to the with extravagant and academics and fun, frolic, everything together.
Yes.
Sure, we are waiting for you all to be here.
It's going to be a great show. So while Sarla ma'am, joins us, we will, go on with the program to invite a special guest and welcome our special guests. Our special guest for the evening is none other than President Bhopal Menopause Society, Dr. Vajanti Kolekar, and President Bhopal Gynae Society, Dr. Abha Jain, and Managing Committee member of ISAR and co-convener of the program, Dr. Randhir Singh. Dr. Vajanti Kolekar, madam, slide. Madam has taken over as the dynamic president of Bhopal Menopause Society earlier this year, and she will be leading the society from the front for the next 2 years, as well as the organizing the biggest event of Indian Menopause Society, that is the National Conference in February of 2026. She has also held the post of Secretary of Bhopal Menopause Society and the Joint Secretary of Bhopal OBGY Society, always been active on the medical, academic, and cultural front, and she is very active in the PCOS Society as well. We welcome you, Vajanti ma'am. We'd like to have a few words from you, madam.
Thank you so much, Monica, for having me today on this webinar. And these synergy webinars are always so interesting and very well designed. So I make it a point always to try and find time to attend them. So I'm really happy to be here with all these excellent speakers today, and really looking forward to have a very good webinar today. And I once again take an opportunity to invite everybody, all the guests and everybody, for our national conference, which we are going to host in the month of February. And Bhopal has got the opportunity. So welcome everybody to Bhopal.
Yes, ma'am. Today is the invitation webinar for Menopause Society Conference. Everybody attending the conference is, warmly invited to our national conference, to the beautiful city of Lakes, to the most beautiful weather of February, and amazing hospitality and cuisine. So
that's what I want to say, that we invite you from the heart of India, Dil Se.
Dil Se. Yes, that is our tagline.
Yeah.
So everything over here will be Dil Se, done Dil Se. So Purva, is Abha Jain madam there?
No, ma'am, not really.
Ma'am has not joined.
So we will wait for Abha Jain ma'am. Has Sarla Jain ma'am joined?
No, ma'am.
Okay. So thanking my co-convener, Dr. Randhir, and I hand over the session now to Dr. Shweta to introduce all the coordinators, including herself.
So we have 5 very hardworking coordinators with us. First of all, Dr. Purva Badkar. Can I have her CV, please? Dr. Purva is currently working as Assistant Professor at OBGY Medical College, Bhopal. And she has more than 8 years of teaching experience. And she has been awarded many prizes. And she is young, but till now she has got oration also. First MPOX Yuva oration was awarded to her in 2024. Next slide, please. Next, we have Dr. Nandini Singh Bhati. She is also Assistant Professor at OBGY Medical College, Bhopal. And she has been trained in high-risk obstetrics and antenatal and gynecological ultrasound. Next. And I'm Dr. Shweta Agarwal, and I'm working at AR as ART Specialist at Ashoka IVF Care, Bhopal. Next slide, please. So next we have Dr. Rita Samadia. Madam is currently working as consultant reproductive medicine at Bansal Hospital, Bhopal, and she is having her postdoctoral fellowship in reproductive medicine from CMC Vellore. And lastly, we have Dr. Shikha Gupta. She is consultant at Dipshika Multispecialty Hospital, Bhopal, and also director. She is having more than 15 years of experience in OBGY, and also she is working as a laparoscopic and hysteroscopic surgeon. And she is also seeing the cosmetic laser procedures, including surgeries and cosmetic reconstructive procedures. So we welcome all the coordinators, and next handing over to Dr. Purva for the next session.
So I must
Thank you,
add a
Dr.
word before session 1, I must add that you can see the coordinators, how we have gathered from all over the city. They range from consultants of medical colleges to, cosmetic gynecologists to laparoscopic surgeons, ART specialists, and fellows in ART, IVF. So that is why we are able to put together such programs in such short notice, because they all give the best in the whatever the field they have expertise in. Thank you to Purva, Nandini, Shweta, Richa, and Shikha.
Thank you so much, ma'am.
We can start session 1.
Yes, ma'am. So, moving to our academic session 1, that is on genetic counseling in prenatal diagnosis. Why, when, how, NIPT current status and future direction. To chair the session, I call upon Dr. Monica Singh ma'am, Dr. Vandana Vansal ma'am, Dr. Rekha Wadhwani ma'am. Dr. Monica Singh ma'am, madam is presently the president-elect of Bhopal Obsgynae Society and convener of
That's okay, Purva. That's okay.
the program. Next, we have Dr. Vandana Vansal ma'am. Madam is free consultant gynecologist at Jeevan Jyoti Hospital, Prayagraj. Madam is gold medalist and first to establish IVF facility in Prayagraj. She is presently President ISOPAB and President-elect of Allahabad Obsgynae Society. She has been awarded with Iconic IVF Unit Year Award, appeared in famous magazine of Forbes, and special interest in infertility, hysteroscopy, laparoscopy, surgery, and cosmetic aesthetics. We welcome you, ma'am, to chair the session.
Thank you, Monica.
Next, we have Dr. Mrs. Rekha Wadhwani, madam. Madam is presently professor and unit head in the Department of OBGY, GMC Bhopal. She has a vast teaching experience of more than 3 decades. She is former vice president and presently executive member of Bhopal Obsgynae Society, also executive member of ISOPAB. She has to her credit various publications in national and international journals and presented various papers in national and state conference. She has been awarded twice CS Dawn Prize and also awards at AICUG. Her special area of interest is high-risk pregnancy. We welcome you, ma'am, to chair the session. Now I hand over the session to our chairpersons to introduce our speaker, ma'am, Dr. Ratna Duapuri, madam.
Good evening, and thank you everyone for the privilege of being here for this talk. I am not able to share my screen.
Madam, we would just like to introduce you formally.
Yes. Okay.
Yes, ma'am.
Okay.
Yes, ma'am.
Thank you.
Dr. Rekha, would you like to do the honors?
Yes, sure. Am I audible?
Yeah,
Yes, ma'am, you are.
there is somebody with 2 devices. So you have to switch off one device, please.
Okay. Am I audible now?
There is echoing. Somebody has logged in with 2 devices.
Okay.
So you have to, Rekha ma'am, you are there in 2 devices.
Just a minute.
Yeah, please log out from one.
Is it okay now?
Yeah.
Yes, ma'am.
Absolutely. So, madam, please introduce Dr.
Yes,
Ratna.
just a minute.
Yeah.
So, good evening and namaskar to one and all. It's my pleasure to introduce our eminent speaker, Madam Ratna Duapuri. She is a senior consultant and chairperson of the Institute of Medical Genetics and Genomics at Sri Gangaram Hospital, New Delhi, a pioneer in the field of medical genetics. And she has made significant contributions to prenatal diagnosis, rare diseases, and genome medicines. She is also the president of the Indian Academy of Medical Genetics and actively involved in national and international research collaboration. And she has also contributed in various publications. And today she will be speaking on the very relevant topic, genetic counseling in prenatal diagnosis, why, when, how, and about the NIPT current status and future direction. Welcome, ma'am.
Ratna ma'am, before you start, I must personally give my thanks and deep gratitude for your acceptance of our, humble invitation to present a talk in Synergy.
Mm.
We are so blessed and honored, madam. Thank you so much.
So thank you so much. I'm privileged to be here. I am sharing my screen. Is it seen and am I heard?
Yes, madam.
Yes.
Okay. So I've been asked to speak in the next half an hour on genetic counseling and prenatal diagnosis, where, when, and how, and also touch upon NIPT, the current status and future directions. So really what I'm going to cover is what is genetic counseling? How do we start from even before a pregnancy is conceived in the preconception period, bring about the concepts through various case scenarios, and then talk about the advantages and the limitations of the non-invasive prenatal screen. So just to give a little background, these are the common genetic disorders, which are abnormalities in chromosome numbers, abnormalities in the structure of chromosomes, and everybody knows that we have 23 pairs of chromosomes in every cell of our body. We also have in these chromosomes 20,000 genes, which can cause different abnormalities. And there are disorders that are related to this. And also there are disorders which occur because of a combination of the impact of genes as well as the environment. And these are called multifactorial disorders. So just to look at some latest statistics, we have 7,000 sorts of genetic disorders. And like I told you, we have 20,000 genes. And at present, we really only understand the function of about 7,600. But what I really want to bring to attention is that this is rapidly evolving. This is data of 2023, where there were 7,400 genes. And in just 1.5 years, you can see where the numbers are rising. So we are really understanding more and more about the human body, but there is still a lot we don't know. And as far as chromosomal disorders go, we know that 50% of the first trimester spontaneous abortions is because of abnormalities in chromosomes. They're also responsible for stillbirths and neonatal deaths, and a large percentage of these are abnormalities of number, and we'll see this. Then coming to the concept of genetic counseling, this is a communication progress that talks about the occurrence and the risk of recurrence of genetic disorders in a family. And the prerequisites for genetic counseling is to understand the disorder and the problem in the family. What are the options and the implications that occur because of that disorder? Helping the family cope with their problem. You need to have extensive knowledge of the disease. How do you confirm the diagnosis? How accurate is that confirmation of diagnosis? What are the limitations of the specific test that we are doing to confirm it? What are the associated comorbidities, the recurrence risk? Who are the other members in that family at risk, etc., etc.? So for common disorders, it's very easy, but very often now there's a total change in the referral patterns, and it is these patients with rare disorders that are referred. And I also tell them, I said, give me 2 days, let me go into the details of that disorder to be able to answer every word that is actually in this last paragraph of my slide. And that is why the patients come. And therefore, this whole concept of genetic counseling is not casual, it's very important. Because after genetic counseling, your family should understand the medical pattern, the facts about that disease. They should understand what is the pattern of inheritance, what are the options that are available to them to prevent the recurrence, what's the appropriate course of action for them. And if there is a living child or an adult with that disorder in the family, how to take care of that affected individual. So there are very many common scenarios for a genetic alert in reproductive medicine. And the first, which I would be talking about, is pre-pregnancy screening. And this is screening to prevent the first occurrence in that family. So it's like a primary screening. And we know that there are two disorders that are common in our country, the hemoglobinopathies, and now we also know that spinal muscular atrophy is equally important. We need to test every pregnant lady for CBC as well as HPLC hemoglobin A2 in the first visit. And if the test has been done in the previous pregnancy, we don't need to repeat it because the carrier status for beta thalassemia is not going to change. So HPLC hemoglobin A2 is done only once. If the woman is a carrier, we screen the husband. If both partners are carriers, only then is there risk of fetus thalassemia where prenatal diagnosis is indicated. And before we do the CDS, we have to identify the mutation in the thalassemia gene in the couple. And therefore, you have to refer in time. Otherwise, the window for prenatal diagnosis keeps going further and further on in pregnancy. The second disorder for which testing should be done is spinal muscular atrophy. Because we have data from India that tells us that the carrier rate is fairly high, it's on an average 1 in 40. And the test that is done for spinal muscular atrophy carrier status is MLPA. It's a DNA based test. And in association with FOXI and the Society of Fetal Medicine, the Society for Indian Academy of Medical Genetics has brought out carrier screening guidelines for genetic disorders. And they will soon be published, and you all are welcome to access the publication. The second scenario that is important is recurrent pregnancy loss and primary amenorrhea or primary infertility. We can see that karyotype here gives us a lot of information for abnormalities of chromosome in the male. If there is oligospermia, then we look for Klinefelter. In a female where there is primary amenorrhea, a karyotype must be done to exclude Turner syndrome, which is one of the causes for a hypergonadotropic hypogonadism. Now, what I want to show you in this case is how important it is to evaluate the entire family. These were two pregnancies where there were major malformations. A lot of testing was not done. And the lady was not counseled before she became pregnant a third time, where again abnormalities were identified. A karyotype was done for the lady, which was reported to have an abnormality in chromosome 12. And it was for this that she was referred to us. Now we understand here that if there is this sort of a part of a chromosome missing, the lady should have abnormality. So we talked to the lady trying to understand if she, didn't get a good education, she was married early, hiding facts, but there was nothing like that. She was well educated, she was fine. And so we decided to repeat the karyotype in my center, and we confirmed that this report was incorrectly interpreted from wherever it was done. The lady was actually a balanced translocation carrier between two chromosomes 12 and 18. The lady would never have a problem, but in the pregnancy, there was a 30% chance of an imbalance as it was in her current ongoing pregnancy, which would be responsible for a phenotype, but a 70% chance that the chromosomes would be normal. So now, armed with this appropriate information and a correct genetic test report, we were able to guide and counsel that family along the correct path. And so I think all of us as doctors who order tests must understand where are we sending the test? What is the quality of the test that's going to come from that lab? What is the interpretation of the test? And we should order the appropriate test. If we are not very, if we don't desire good quality, the companies will not give it. But if we understand it and we insist on good quality, the lab will provide good quality. Then we come to scenarios like a positive family history. Look at this. Two sisters where recurrent abnormalities are identified in the fetus. So it should ring a bell that we could be dealing with something common. The most easy thing to test is a karyotype of the lady. And if you do that karyotype, you understand that again, they are balanced translocation carriers. And this is why their pregnancy was impacted. And now we can guide them. So once we are armed with the correct information, genetic counseling then can follow a specific path. If we don't understand why something happens, it's very difficult to counsel the families. We can get a lot of information just from simple conversation and simple things like pedigree analysis. You can see here that here there is thalassemia. We must evaluate. And when we evaluate anybody who's a beta thalassemia carrier, we must inform them that their siblings are also at a risk of being carriers and therefore should be tested. This is a family who was sent to me to evaluate for short stature and to discontinue the pregnancy. However, when I went into the history, everybody in this family was short. And this was a non-lethal kind of skeletal dysplasia. And the first death had happened because they had not been careful and transferred the baby when the baby was small. That resulted in an intracranial hemorrhage because of the lack of protective cranium. So when I spoke to this family about all these details, they said, we are fine. We don't want to terminate the pregnancy because we are only short, but intellectually we are fine. All I told them was that just deliver the baby where there is a good nursery and you don't need to transfer the baby anymore. And so today they have a child who's doing very well, though the child is short. This starts off like my brother has polio. But if you go into the details, and this was the person with polio, but you realize that there are so many other affected members in the family. And even siblings may not give the correct information to each other, because here this was Duchenne muscular dystrophy and X-linked disorder. And her sister knew about this, had undergone testing. But, these are stigmas of genetic disorders in family. And therefore, if you gently speak to them, they will come out with all the information. And so there are so many stories like this. But I think as obstetricians, what is very important to appreciate is a scenario where there is recurrent polyhydramnios. It obviously, if the diabetes is okay, we need to think ahead. We need to understand and evaluate why this is happening before we get situations like this, where there are early neonatal deaths because these children do not establish good respiration. And this is because of a neuromuscular disorder, which is called congenital myotonic dystrophy. And if we go down the family history, all this is that is labeled as polio is actually not polio, but a milder manifestation of this severe disorder, because of which there are intrauterine deaths as well as neonatal deaths. And these are all preventable anomalies. But making the correct diagnosis is the first step in being able to counsel these families for the correct course of action. And so if you have worked up, like in this family, who had autosomal dominant cardiomyopathy, where this lady actually was in failure when she came to our hospital, because she had decompensated in pregnancy, because they had never revealed this history, or no one had actually given attention to this history. But once the workup was done, the genetic basis was understood. It was very clear that the lady could not go through another pregnancy because of her delicate state. But with all this information, we were able to guide her for surrogacy. She could use her own egg and then have PGTM done, and therefore have a successful outcomes. So these sort of families really teach you that we could have prevented all this. She could have died, but having the correct information and delving and speaking to the families, we could have prevented so many things. There are some disorders where there are multiple members affected in the family, including the lady who has given birth to the child, but the expression of that disease is different. And this is very, very common in autosomal dominant disorders. And this is an example where this baby was born very early, preterm, 860 grams, slightly small also, developed abdominal distension, underwent laparotomy, had a stomy course, and etc., etc. You can see what a bad outcome this child had. But when we went into the details, the lady told us, yes, my first child also has difficulty in walking. I also am able to walk, but if I walk very long, if I take a long, a very tall flight of stairs, I have a problem. Because these members in the family were suffering from a muscular myopathy because of a mutation in the RYR1 gene. In the mother, the presentation was mild. In this baby, it was very severe. But if all this information was available, we could have prevented this laparotomy and all the impact of a surgery in such a small baby. Because this abdominal distension was actually a manifestation of muscle weakness. And so therefore, just speaking to the family, taking a history, drawing a pedigree helps us a lot. So with all that in the background, what I wanted to bring out is, coming back to my first slide of genetic counseling, is understanding the disorder in the family, making a correct diagnosis so that you are able to guide the family for the care of the affected as well as the future reproductive options and the steps that need to be taken. I come to the second part of my talk, that is on the non-invasive prenatal screening. So first we have to appreciate what are we testing for. We can see we test for Down syndrome that affects 1 in 1,000 live births. But on the other hand, we have something like a neural tube defect with which children are still being born. And the incidence and the prevalence is much more. It can be very, very severe and life-threatening, again, in a large percentage of babies. Down syndrome is rarely life-threatening. The phenotype is developmental delay, but it is trainable. Whereas neural tube defect, you can have severe intellectual problems depending upon the extent of the Chiari malformation as well as physical disability. So while all of us have learned to screen for Down syndrome, we still need to learn to screen for NTD and to start periconceptional folic acid, because, I just feel that all these screenings have come to light because a lot of companies are there around and educating all of us. But we as physicians should not, lose our the concept with which screening is really relevant. And there are other disorders other than Down syndrome which need to be looked for with equal seriousness. So talking about screening test, a screening test is something that is applied to a large population. So we can screen for Down syndrome. We use the ultrasound to screen for structural abnormalities. We screen for thalassemia and SMA. So I have alluded to all of these. Beyond that, we screen for Down syndrome using aneuploidy, blood screening for chromosomal abnormality, ultrasound, we've done this. The thing about a screening test is it's not an expensive test, can be applied to a population at large. But What the screening test does is it screens out a positive population to which a confirmatory diagnosis has to be established using a diagnostic test. These tests are expensive because they're very specialized tests, but their advantage is it gives a confirmed diagnosis. So a lot is now available for screening for Down syndrome, depending upon which gestation the lady comes in. In the first trimester, we have the first trimester screening that has got a good sensitivity. In the second trimester, we have quadruple test, again, which has a fairly decent sensitivity if done properly. Triple test is not recommended because the sensitivity is low. And cell-free DNA testing, which is NIPT, can be done across all trimesters. It has the highest sensitivity for a very small false positive rate. Sorry, this should be 0.5%. So the array is wide and no one test is superior in all circumstances. We understand because it's a screening test, we apply it to all the pregnant women. The choice of test is patient-centric and depending upon the informed patient choice. It should not be that get this test done, otherwise don't come back to me. If the couple feels they don't want to do any screening for Down syndrome, it's fine. It's their responsibility, as long as it's an informed patient choice and they understand what they're doing. But as doctors, which is very important for us, is we apply only one screening approach and not multiple screening tests. We don't do the first trimester screen and then go and do the quadruple screen, just one test. In our country, the second screening test that we can employ is the NIPT if either of these are screen positive. But if the first trimester is low risk, we would not do a quadruple screen. So, like I always say, that the expectation from an academic society, all of which each one of us is a part of, it is important to be sensitive to the patients. No screening test is mandatory. It's the choice of the couple, and it should not impact the obstetric management of the. Now, what is cell-free DNA? This is the free DNA that is present in the blood. It comes from the placental cells that are naturally dying in the placenta. So remember, it's representative of the fetus. It is not directly fetal, and therefore it's a screening test and not a diagnostic test. And after 9 weeks of pregnancy, we get cell-free fetal DNA, and in the postpartum period, it disappears. So these are the things that it's standardized for, RH and the common 3 aneuploidies. Beyond that, we can test for sex chromosomal abnormalities, other autosomal chromosomal abnormalities, deletions and duplications, which are referred to as copy number variations. We also get information of various maternal conditions, and I'll be talking about these in my subsequent slides. And there is also data now to tell us we can screen for single gene disorders like achondroplasia, etc. So there is a huge amount of possibility, but it's also important for us to understand the limitations before we use the test. For rhesus, it's a great test. You can do it, understand whether your fetus is Rh negative or Rh positive. The test is done between 11 and 28 weeks. There's no hurry because you're not going to start screening before 16 weeks or 18 weeks. And this is like a standard of care, and we routinely do it in my hospital because we use this test in-house. So actually, I think this is an important slide because we know that we are in a great era. What we are seeing in this era was something that was never conceived. But along with all that, there comes a great sense of responsibility for us to use this technology for the benefit of the patient and the benefit of the fetus. And therefore, there remains a great debate on what more should we do and what less. How should we go forward? Okay. So the cell-free fetal DNA is a great test because it's a blood test, it's non-invasive, and it's very good for trisomy 13, 18, 21 as a screening test because it's got a sensitivity of 98 to 99%. Okay, so it's got a very, very good positive predictive value, as you can see here. So 98 to 99%, we can be very sure that we would pick up these babies for the 3 chromosomal disorders, whether it's a singleton or it's a twin pregnancy. However, it's very important before we do this test to ensure that the patient has understood what the test is. It cannot be ordered like a CBC. What happens if the screen is positive? Does a negative test actually mean that the baby is genetically normal? There are various ambiguities in the result. Sometimes we don't get a result. Sometimes we don't understand because we are not able to sequence the DNA. These are limitations of the test. And very importantly, that even after doing the test, there is a residual risk because, like I told you, it's not a diagnostic test. The pickup rate is 98 to 99%. So it doesn't exclude all genetic disorders. And if it is screen positive, it does not mean that the baby has Down syndrome. It means that we have to go and do the definitive test, if you remember the first screening slide that I showed. So all this requires time. And in fact, it is very interesting that there is this paper from America also where they have so many genetic counselors about the time that was spent by the health professionals on counseling just for using NIPT for the 3 disorders, 13, 18, and 21. And 36% spent less than 5 minutes, 39% spent about 5 to 9 minutes, and they had just about 6 minutes answering the questions of the couple and the family. And so in our practice, if we can ensure that we can at least give a minimum of 10 minutes to explain what the test is, why are we doing it, what are the implications of the test, the advantages versus the limitations. If it comes screen positive, what they have to do, then I think we are fine in doing the NIPT. So I'm just going to take you through some cases. This was a family where the first child had intellectual disability and microcephaly. They had done a chromosomal microarray on the child. It was normal. So that means it was not a chromosomal cause for that phenotype. Now, in the pregnancy, the NIPT was done, which was low risk. But what the family understood was that because they had done an expensive test, a genetic test, they were ensured that the fetus is not going to be affected like the first child. Now that is very important because the second child was again born with microcephaly at birth. So it's important for us to counsel these families that this test has nothing to do with what the first baby had. It cannot prevent that because we haven't understood why that first baby was affected and more workup was required for them. So NIPT was actually not the test to do in this family to exclude the risk in view of the family history. So if there is a positive family history, we have to evaluate the proband before we can do any form of prenatal diagnosis in that family. Okay. The second case, triple test positive at 18 weeks. Probably the first trimester screen was missed. It was 1 in 100. NIPT done at 19 weeks. The fetal fraction was low. That means there was not enough fetal DNA, and therefore the result was not given. A repeat sample was sent, but the pregnancy was going forward. NIPT takes 2 weeks for the report to come back. And the family got very scared and they just went and aborted the pregnancy. We looked at the fetus in an autopsy. There were no features of trisomy 18 and the karyotype of the fetus was normal. So this was actually a normal baby that had been discontinued because we had not given appropriate pre-test counseling and had the patient understand what all this testing is. And this I'm just showing a little bit of data from my laboratory where what I really want to show you is that every NIPT These were all high-risk NIPT that came in for definitive testing. And you can see how many of these reports are actually normal. So therefore, every NIPT must be tested by a diagnostic test, which is amniocentesis and a karyotype. The best sensitivity is for chromosome 21. For the other rare chromosomal abnormalities, all the chromosomes were normal in the baby, even though the NIPT had flagged off a positive result. Now, why do we get these false positive NIPT? There are placental causes and maternal causes. Placental causes could be placental mosaicism, which is limited to the placenta. Remember, what you're testing in the NIPT are placental cells. And so it may not be fully representative of the baby. And you can get a false positive because of that. You can also get a false positive because of a vanishing twin, because we know that 50% of these vanishing twins are actually chromosomally abnormal. And so the NIPT picks up the DNA of that twin that has vanished. It could also be technical reasons because of a high BMI, a lot of fat cells, it overpowers the fetal cells and we are not able to do the test. It could be various maternal reasons. As age advances, we know that a few percentage of women lose an X chromosome, so you can get increasing sex chromosomal abnormality. Or the lady may be such a low mosaic. She has no features because of that, no problems because of that. But when you test it, you identify that she is a low mosaic for a chromosomal abnormality. Any malignancy, organ transplant, very, very big fibroids can give false positive results. So vanishing twin is a big thing. I prefer not to do an NIPT, but if you really want to do it, you can do it after 3 months because that's about 14 to 15 weeks, not before that. Every high-risk positive NIPT must be confirmed by invasive testing. Should you do a CVS? Should you do an amniocentesis? Depends upon what the chromosomal abnormality is. If it's related to chromosome 13 or monosomy X, we prefer to do amniocentesis because there's a lot of confined placental mosaicism for these chromosomes. So, to cut a long story short, I think it's fine to do and amniocentesis. Unless at 12 weeks you've got a NIPT positive for Down syndrome, in that case you can do a CVS to confirm the chromosomes of the baby. But no pregnancy should be discontinued without a definitive test. Now, what I want to show you here is, this is really 2 babies, 3rd pregnancy, bad obstetric history. And the NIPT was done because of advanced maternal age. It was high risk for trisomy 13. We did the CVS. There was mosaicism. 70% of the cells were fine, but 30% showed an abnormality. So we did an amniocentesis because we knew that it could be confined placental mosaicism. And here the chromosomes were normal, telling us that the fetal cells were normal and the fetus is not affected and the pregnancy was continued and the baby delivered was. The second thing is, should we do these extended tests looking at all chromosomes, looking at deletions and duplications? There is data to tell us that at present, there is not sufficient data to tell us that this test is sensitive for these deletions and duplications and the expanded genomic NIPT that is, done by all companies and they charge a lot of money. These disorders are rare and therefore they don't need to be tested by this technology. What about the rare autosomal aneuploidy? So these are all guidelines by the American College of OB/GYN, the American College of Medical Genetics, and all of them feel that right now it's fair to limit it to the 5 common chromosomal aneuploidies. Many countries don't even do it for sex chromosomal abnormalities because the false positive rate is high. Because excessive testing leads to excessive implications for additional testing because you get a lot of false positives and you'll be going and doing different technologies to confirm the abnormality depending upon what chromosome has actually been identified. And because this is a predominantly commercial-driven activity, the guidelines very clearly put forward that the sponsors and advocates of this huge genome-wide NIPT, which they say can detect anything and everything, require to bring more data and to do clinical trials in a systematic way before we can have a clear pathway and guideline that these testings has to be done. It should not be a force. NIPT, if there are twin pregnancies without fetal demise, you can do NIPT. It's a good screening test. However, if there is fetal demise, there can be a higher rate of false positive because of that fetal demise. So this sort of test has to be, this sort of counseling has to be given to the family. If it is negative, it's fine. But if it is positive, we will have to test the fetus by doing an invasive screen. Sex chromosomal abnormality, I think there's a lot of debate because none of these are causing mental retardation or intellectual disability. There is treatment for Turner syndrome. All of you are obstetricians. You know that we can treat Turner syndrome, and there are many other causes of infertility where the chromosomes are normal. Okay, so there is a lot of debate that do we actually test fetuses which are then discontinued for abnormalities which are not associated with a lot of morbidity and mortality. It's a debate. It's for all of us to have that debate and to decide what we want to do in our country. Right now, we just flow with the tide. And in my heart, I don't think that's the right thing. I think we need to sit and sort out our own recommendations that what should we test for and what we should not test for. Because after all, it's a live birth we are dealing with. And we are terminating pregnancies for indications that probably are not indicated also. Because we don't know how many people there are with these sex chromosomal abnormalities who actually have no problem at all. But now because antenatal testing is available, we are just identifying more and more, much more than they are identified postnatally. So these things are important to understand. Another important thing is, if the NIPT is low risk, what is the chance that it is a false negative? The false negative rates are low, as you can see here, but this forms a very important and a legally important part of counseling the families. Because you can have, I have seen children with Down syndrome after a low NIPT. So it's something that's well reported and should be a part of our counseling. And so before I conclude, where are we now? Actually, the lines of screening are being blurred. We started with these 3 severe disorders, which have intellectual disability. We went on to say, let's screen for all chromosomes. Let's screen for preeclampsia. Well, this is good because there is treatment. Screen for infections, screen for all genetic disorders. The lines are getting blurred. And the burden on the families to screen for everything without really coming to a conclusive diagnosis is becoming more and more. Okay? We need to screen for things that are a burden in our society, that have a good screening test, where there is no great false positive rate. You also need to stress on providing newborn screening. Okay, so here you can see that as the number of tests for which genomic screening is being done, the clinical relevance is going down, the false positive rate is going up, and the anxiety levels and unnecessary termination of pregnancies are going on increasing. It's not as if 10 years ago, a lot of genetically abnormal children were being born. It's not like that. So within a larger framework, we as doctors and custodians of health and actually custodians of life for the fetus, that's what I've started feeling now, have to understand that 95% of the families they will deliver normally. There is a 3 to 5% risk that they can be a genetic disorder. We need to screen by ultrasound for major anomalies, especially neural tube defects, common chromosomal disorders. We need to do preconception carrier screening for thalassemia and SMA, which are very severe disorders. Sex chromosomal abnormalities, we need to think and come to a consensus what we need to do because these are not disabling disorders. For all the additional genome-wide screening, I think it's too premature to offer that. And it's not only I, the world thinks it's too premature to offer. But we need to ensure that every baby born gets newborn screening done. And so with that, I end my talk. Thank you so much.
Thank you,
I'm
madam.
open to take any questions.
Thank you, ma'am. Your comments, Dr. Vandana Bansal, madam?
Yeah. Thank you, ma'am, for this extensive and elaborating lecture on this genetic counseling, which is so important these days. And you're talking so high about the NIPT. In many a time, I saw that one of my patient whom I did IUI, she had double test positive, and she did not come to me. She went to some other gynecologist and she aborted. So this
It's a
is
big
the
challenge. It's a
situation.
big challenge.
Yeah, it's a big challenge because we as a obstetrician, we have to explain whenever we write that even the double test or whatever test, as you said, that giving time and explaining what we are writing, what are its implications, and if it is, that is very, very important. If we do not explain that time, if that is positive, she may go to other doctor and she may abort it, and she can be worried. And also, you opened, my brain that NIPT can be done in so many other things. So knowing if then the RH positivity or negativity of the child is very important. I think that is very extremely good indication for NIPT. And of course, when the baby family had a family history of like microcephaly or anything, so there the NIPT do not have
It's
any.
not a good test.
And all the tests should always be combined with the good ultrasound. That is very, very important. Thank you, ma'am.
Thank you.
So that is going to be the continuation of Dr. Ratna madam's talk when Dr. Divya will tell us how ultrasound can really compound your diagnosis.
Yeah.
Because as I told you, the genetic testing may be something which is not very tangible, but ultrasound is something for you to see and
Everybody.
detect and diagnose. And you can always have a second opinion of experts. I think all ultrasound people vouch for it, that if you have any doubt in any image or some abnormality which you feel you cannot decipher, it's always good to take a second opinion. So Ratna ma'am, that was a brilliant talk. And you talked about some sex chromosomal abnormalities which are compatible with life but are yet detected by NIPT.
Yes.
Yes, ma'am.
So if I can just say that all sex chromosomal abnormalities are compatible with life. Patients with Turner syndrome, where there is only one X chromosome, have short stature, which today is treated with growth hormone. And they have infertility, because they have hypergonadotropic hypogonadism, which also has treatment. Because I think there are more patients with hypergonadotropic hypogonadism and normal chromosomes than patients with Turner syndrome. So why should we abort these women who are intellectually normal? We have patients of Turner syndrome who are sitting in Harvard. So it's very disturbing. And the rest of the sex chromosomal abnormalities, XXY, again has male infertility, but intellectually normal. XXX and XYY have absolutely no postnatal manifestations. There is so much data now that is coming in that is telling us that prenatal identification is identifying more cases than postnatal. And the reason for that is because they don't manifest postnatally. Most of them, a few of them can have some minor problems, behavior problems, mild delays, but most of them are normal and therefore they are not tested. So therefore, for sex chromosomal abnormalities, I think the counseling has to be very, very strong, very, very strong. And if we counsel these first, should we test or not? But because the commercial companies provide a package, they are tested. If there is an abnormality and it is confirmed, our counseling has to be very strong. And if our counseling is strong and we give time to the families, they would not discontinue the pregnancy.
Thank you, ma'am. And I also feel the genetic counseling has to be taught from scratch, even to obstetricians, because when I attended a genetic course of ICOG, it was very comprehensive. Ratna ma'am, probably you were also there as one of faculty. So they actually taught us how to make this diagram, what is a proband, how do you trace a family history? Because sometimes when you show us these diagrams, case number 1, 2, 3, our minds get confused as to which sibling, which generation you're talking about. So if that diagram appears in front of our eyes multiple times, then as obstetricians, we will be more likely to recognize and, understand and explain the patient that family thing. The
Can I
tree.
say something?
Yes,
Yeah.
ma'am.
Monica, I think we all of us are so busy in our practice that I think we can understand everything. But the proper genetic counseling has to be done by somebody expert in it, because it is a very vast subject and it's a lot of time. One genetic counseling needs at least 20 minutes, not less than that. So it has to be done by somebody who is expert in it, because everybody cannot do everything like IVF, laparoscopic surgery, and obstetrician, and we can tell our patients, but there should be a proper person, genetic counselor, genetician, to do that.
But if
I
like
think taking a history and those basic
that
things,
everything.
and then who
Yeah.
to refer to.
Yeah,
Bas, that's what's
definitely.
required. Yeah.
And then if you don't have the genetic counselor, then the online consultation can be done. These days, though, it is very easy. We can consult.
COVID has taught us a lot.
Yeah,
I mean, it's taken away a lot, but it taught
Yeah.
us that online counseling can happen without disturbing the family and the
So
patient.
we have to
That's
understand, we have to have a understanding, but we don't have that much of time to spend with the patient. We can write the test and we can make them understand basic things. Only we have to make them understand. But for the higher things, we need the person expert in it.
Madam, we would really appreciate if you could share with us the emails and phone numbers of some online counselors, genetic counselors.
Yeah,
for
yeah,
benefit
ma'am.
of the-
That
for
will be
benefit
great.
Yeah,
of the-
Dr. Monica, I will share that with you. The ones
Yes.
who are well trained, the geneticists. So
Yeah.
we have two types. We have geneticists, we have genetic counselors who are not doctors. But at present, that training is still a little not so good in our country. But I will definitely share with you, Dr. Monica, the geneticists.
Yeah, thank
And
you
so online consultations can be taken.
Yeah,
It's no problem.
ma'am, my granddaughter, my daughter-in-law was trained under you, Dr. Sakshi Rajoria.
Oh, of course, of course. Oh, that's wonderful. How
Yeah.
nice that is.
Yeah.
So thank you, Dr. Ratna ma'am, for the beautiful lecture, which was an eye-opener for all of us. And I think we can now, with permission of the entire chair, we can move on to session 2. So
Dr. Sarla Jain ma'am has joined, ma'am.
Yes. So Dr. Sarla Jain, our guest of honor, is here. We will, just break the session for 1 minute and take words of blessings from Sarla ma'am. Dr. Vishal?
Monica.
Yes, ma'am. Ma'am, we have already introduced you as a very,
Yes.
very vitally important part of Bhopal Menopause Society as well as Bhopal OBGY Society, alumnus of GMC. So, madam, would you like to
Thank you, Monica.
Yes, ma'am. So, would you like to speak to
Thank
us?
you.
Yeah. Ma'am, your thoughts about this program and what do you think about
Yes.
the Ratna madam's it just happened?
Ratna madam is explained is very well. Or we thought every patient is should go for prenatal diagnostic. And as you advise, Monica, we always behind you. Thank you. Thank you. Monica.
Thank you, Sarla ma'am. Thank you. So over to you, Dr. Shweta, for session 2.
Yes, for moving on to session 2, can I have the slides? Topic is ultrasound a window into prenatal genetics. And we have dynamic chairpersons with us. First of all, we have
Please,
Dr. Manjushri Bhu, madam.
yeah, Shweta, your network might be a little unstable, so just move into better
Slide,
network.
please.
Yeah, your voice is breaking in between.
Okay, ma'am.
Maybe some network
Okay.
issue you can solve. Yeah, thank you.
Okay, ma'am. Dr. Manjushri, madam, has been awarded Vigyan Vardhan Award, Best Paper Award, Best Poster Award. Madam is an excellent academician as well as OBGYN specialist, and she has been advanced laparoscopic and hysteroscopic surgeon, and also an ART specialist. Ma'am has written and published a book on adolescent health, sex education for blind students in Braille, which book was inaugurated by at Rashtrapati Bhavan by Mrs. Pratibha Patil and distributed all over India to blind libraries free of charge. We welcome you, ma'am.
Thank you so much. Thank you so much. Carrying forward for the next session after a
Madam,
very good.
just a minute, madam,
Am I
just-
audible? Am I audible?
Madam, one more chairperson is there. Two more chairpersons are there.
Okay.
Just give us a minute, madam. Yeah,
Dr. Anita ma'am has not joined. She is in emergency right now.
right. We can go.
Next, we have Dr. Varuna Pathak, madam. Varuna Madam CV, please. She is a professor, OBGYN specialist at Ramakrishna Medical College, Bhopal. Madam has more than 20 years of experience, and Madam is chairperson, Women Wing IMA at Greater Bhopal. She was ex-vice president of Bhopal OBGY Society 2017 and 18, ex-secretary Bhopal OBGY India 2013 and 2014, and Madam has played an excellent role in all the wings which Bhopal is like working. And presently now she is executive member of IMA Bhopal. We welcome you, ma'am. Over to chairperson for introduction of our speaker.
Take over? Can I take over? After a brainstorming session of prenatal genetics, it's really in this era of where we are moving forward, we should not deliver any baby with anomaly and definitely not with any genetic abnormality too. And how is a way forward is another talk which will be delivered by Divya Singh ma'am, and she is MD DNB she's MBBS gold medalist from IGMC Shimla, and she is PGI Chandigarh MD radio diagnosis with bronze medal. She's fellow advanced OBGY ultrasound from Mediscan Chennai, and at Mediscan I know her because I was there, and she teaches excellent short-term training she takes in medical genetics through ICMR Mumbai. She's currently a consultant radiologist, Mirchia's Diagnostic Center, Chandigarh. She is a chairperson for IS-UOG CME, subcommittee member for IS-UOG Outreach and Education Committee. She has been awarded by Ministry of Health, Government of India for providing exemplary service to pregnant women in Chandigarh. Best oral paper on ultrasound in endometriosis in Sonocon 2020. She has 57 publication and conference paper with 2 chapters written in the books. I know ma'am is excellent for the topic, and whole stage is your Divya Singh ma'am, and we are really waiting to hear you.
Before
Good evening,
Divya,
everyone.
before Dr. Divya starts her talk, I must personally extend gratitude to Dr. Divya for once again accepting the invitation of Synergy Academic Club. And she is my teacher as well, and a very, very avid academician. Thank you, Divya. Though you're much younger to me, your knowledge knows no bound as far as ultrasound. You're a magician when you speak. Welcome to Synergy.
Good evening, everyone. I think ma'am, Dr. Monica ma'am has overwhelmed me with the praise that she has showered. And in the next 30 minutes or so, I have to do justice to whatever the Honorable Chairperson and Monica ma'am have they expect me to do. The stage has been set by Dr. Ratnapuri ma'am because she's one of the doyens of genetics in the country. And she has already set the stage for this webinar. So I will be starting with my presentation, which is how ultrasound can act as a window into prenatal genetics. So today, ultrasound, especially since the technology has evolved so much and we have high resolution equipment, it works hand in hand with genetics. And what prenatal ultrasound can do is, as we understand, it can identify soft markers for aneuploidy. We can look for structural anomalies using ultrasound. And once we have these, we try to link them to various genetic conditions. This helps in guiding further genetic testing. In fact, when we perform procedures like chorionic villus sampling, amniocentesis, or cord blood sampling, we use ultrasound guidance. And of course, once we have the diagnosis, it facilitates in genetic counseling and prognostication so that the couple can make an informed decision regarding the pregnancy. Now, the various ultrasound soft markers that we look for in the first trimester, I think everybody knows them, but just for refreshment, we have a thickened nuchal translucency. We look for the unossified nasal bone, tricuspid regurgitation, and reversal of A wave in the ductus venosus. Now, why are these things called as soft markers? They are called as soft markers because they are not structural abnormalities per se, but when they are present, they increase the age-adjusted risk for aneuploidy. So just mere presence of these should not lead to an unnecessary termination of pregnancy because these are not structural abnormalities and their presence warrants further testing. The various second trimester ultrasound soft markers that we all know include echogenic intracardiac focus, pilectasis, thickened nuchal fold, hypoplastic or absent nasal bone, mild ventriculomegaly, echogenic bowel, a short femur or humerus, and aberrant right subclavian artery. But here again, what I would like to draw your attention would be towards these first two soft markers, which if present in isolation, do not actually significantly increase the risk for aneuploidy. And so today, if we see these soft markers, that is echogenic intracardiac focus or pilectasis, that is mild pilectasis in isolation in the second trimester, we do not pay much attention. They do not increase the age-adjusted risk for aneuploidy. On the other hand, the likelihood ratio or the factor by which the risk for aneuploidy is increased is much higher for these soft markers like a thickened nuchal fold or an unossified nasal bone, mild ventriculomegaly, and aberrant right subclavian artery. And these are the markers which often warrant further testing. Now, this is just to show you a transvaginal ultrasound clip of a fetus at 12 weeks. And you can appreciate, even if I don't show you the mid-sagittal image, the marked thickening of the nuchal translucency as well as extensive subcutaneous edema. So this is what we see typically, an indication for prenatal genetic testing in the first trimester, a thick nuchal translucency. And even if I don't show you the measurement, this measurement was way beyond 3.5. It was around 6.5 millimeters, the nuchal translucency. And as a consequence, since this was an isolated finding and the couple wanted to know if there was any kind of a chromosomal abnormality, we went in and did a chorionic villus sampling. As you can see, this is just a clip to show you how ultrasound can be used to provide guidance in order to sample the placenta in the first trimester. And the chorionic villus sampling report was sent for a karyotype, which revealed a 45XO, that is monosomy X, and which is Turner syndrome. So this is how ultrasound plays a role right from identification of a marker and then performing a genetic test. Now, this is another case, Mrs. A, 22-year-old primi gravida with a non-consanguineous marriage and a spontaneous conception. She did not have a significant medical or family history. The first trimester NT scan showed a nuchal translucency thickness of 3.9 millimeters. Again, typically, nuchal translucency thickness of more than 3 millimeters by ACOG is an indication for direct testing. And this couple was offered the option of direct testing, which they took. CVS was done and the sample was sent for genetic tests, as well as DNA was stored. No pathogenic copy number variant was detected. And so this fetus was chromosomally normal. However, we do not stop here when we see a thickened NT. The fetus was reassessed at the early anomaly scan at around 16 to 17 weeks in the second trimester. At that time, the nuchal fold thickness was totally normal and there was no other structural abnormality. The pregnancy was followed up, no further testing was done, and it ended up being an uneventful pregnancy with the birth of a normal child. So this is just to show you two ends of the spectrum. On one end, a thickened NT with an abnormal karyotype, and on the other hand, it's possible to have a thickened nuchal translucency and have a chromosomally normal child. So one should not make any hasty decision just based on these soft markers. And once you come across thickened nuchal translucency, it's important to go through the cascade of further testing and ultrasound evaluation before making an informed decision regarding the pregnancy. Now, this is another case of Mrs. B, a 32-year-old lady who came to us in her second pregnancy. She had one previous live issue who was normal. Again, this was a spontaneous conception, non-consanguineous marriage with no significant medical or family history. At her NT scan, the nuchal translucency was very thick, around 5.8 millimeters. And that is why she was offered the option of chorionic villus sampling, and the sample was sent for these tests to establish chromosomal normalcy. DNA was stored again at this point of time, and again, the report of chromosomal microarray came back as normal. As I said, our work doesn't stop here. We see the patient again during the anomaly scan, and she came to us for the anomaly scan at 18 weeks. But in this case, as you can see in this axial image of the head at the level of the transcerebellar plane, there was this marked thickening of the nuchal fold. So in the previous patient, I told you the nuchal fold had regressed, but in this case, the nuchal fold thickness had actually markedly increased. It was as thick as 11 millimeters. And so this was not reassuring. And we wanted to test this child further because remember, we had stored the DNA at the time of CVS. The patient did not want to continue the pregnancy. So she went on to terminate the pregnancy. However, the stored DNA was tested, and what was found was a heterozygous pathogenic variant in this gene, which is responsible for a single gene disorder known as Noonan syndrome. So this is how I've shown you 3 cases with the same soft marker, that is a thickened nuchal translucency, but having very different outcomes. So the take-home message is that whenever you see a thickened nuchal translucency, please remember that it is just a marker. It is a marker for chromosomal issues, that is aneuploidy, single gene disorders, and cardiac abnormalities. So it's very important that a fetus with a thickened nuchal translucency is assessed anatomically in detail, because sometimes the NT scan is just measurement of the NT, CRL, and looking at the nasal bone. But that should not be the case. There has to be a complete structural evaluation of the fetus during the NT scan, especially if there's a thickened nuchal translucency. We offer the option of direct testing when the nuchal translucency is 3 millimeters or more. Also, it's important to remember that just because an NT has regressed, it doesn't imply that the risk for the fetus has reduced, because sometimes what happens is you see a report at which in which there was a thickened nuchal translucency at 11 weeks, but if the patient comes to you for a second opinion and you see that the nuchal translucency is now not thick, one should not go with the idea that it means that the fetus doesn't have a risk for aneuploidy. In fact, whenever you see a report which says thickened nuchal translucency, it's important that you look at the images of that report and make sure if the NT has been measured correctly before deciding on further course of action. Also, please remember that thickened nuchal translucency is not an indication for direct termination of pregnancy without further testing. The various genetic tests that are done initially are usually to test for chromosomal issues. Studies have seen that doing prenatal testing for exomes, especially in cases of isolated nuchal translucency, doesn't have a very high yield. And that is why this is something that we have to think before we offer, especially in limited resource setting like ours. There are some people who offer testing for rasopathies, that is conditions like, which the Noonan syndrome also falls in the spectrum of rasopathy if the NT is more than 5 millimeters. Now we come to another case of Mrs. X, a 29-year-old lady. She was a surrogate and had conceived via IVF. She had DCDA twins. She had hypothyroidism, which was controlled on medication, and her twin A, that is the fetus towards the cervix, was reported to have an unossified nasal bone in the first trimester scan. As you can see here, we cannot see the nasal bone in its normal location. So the fetus not only had an unossified nasal bone, when we did the assessment of the heart, there was also another soft marker, that is the aberrant right subclavian artery. And why do I say that it is aberrant is because the normal subclavian artery normally courses towards the right shoulder anterior to the trachea. But an aberrant one goes behind the trachea to the right shoulder, and hence there were two soft markers which significantly increased the risk of aneuploidy in her case. Today we have reporting softwares in which we just enter the presence of markers and the software automatically calculates the risk for us. But behind those softwares, what acts is this table. And as you can see here, aberrant right subclavian artery and an absent or a hypoplastic nasal bone have a very high positive likelihood ratio for trisomy 21. And hence, this patient was offered the option of direct testing. And that is what she opted for. So amniocentesis was done, and that confirmed the presence of trisomy 21 in twin A. Then we move to another case, that is of Mrs. P, 28-year-old. This was her third pregnancy when we saw her, and she had 2 previous losses. Again, her marriage was non-consanguineous. In the first pregnancy, there was a termination of that pregnancy at 20 weeks. She did not have any records except for the fact that the fetus was a male fetus and had short, long bones. In the second pregnancy, she had undergone an ultrasound again at 18 weeks, which was reported to have short, long bones and an atrioventricular septal defect, so a cardiac anomaly. Based on this report, again, the couple opted for termination of pregnancy. But fortunately, at this time, a detailed postnatal evaluation in the form of autopsy was done. It was a female fetus who had short, long bones, which had normal contour and mineralization. There was presence of the AVSD. In addition, something which was not reported on ultrasound, but was reported on autopsy was the presence of bilateral upper limb post-axial polydactyly. And based on the findings of autopsy and the fetogram, a diagnosis of Ellis-Van Creveld syndrome was proposed. So this goes to show how important it is to subject a fetus, especially anomalous fetus, for a postnatal evaluation or an autopsy, because that gives you a wealth of information which can be very helpful in the subsequent pregnancy, as was the case in this lady. She came to us at 12 weeks. And since we already had this information with us, we looked at the fetus carefully, and just looking at the limbs, we could appreciate that the child had really short bones. Also, when we looked at the hand, you can see here in this image, both the hands showed presence of 6 digits. So this was the thumb, 1, the index finger, the middle, the ring, the little, and then there was another nubbin of soft tissue, that is another digit which was present lateral to the little finger. So this baby had short, long bones, bilateral upper limb post-axial polydactyly. Also, since we knew that there was some issue in the heart, we assessed the heart at 12 weeks using high-resolution probe. And you can appreciate here that this 4-chamber view is not normal at all. We could not see the normal septum primum. There was an inlet ventricular septal defect, and we could just see a single common atrioventricular valve. The separate mitral and the tricuspid valves could not be seen. This is also appreciated in this Doppler image, where you can see that there is just a single atrioventricular valve, and so this fetus also had an atrioventricular septal defect. And now, since we had that previous history, we knew that we were dealing with a case of recurrent Ellis-Van Creveld syndrome. So again, the lady opted for termination of pregnancy, and this time, however, before undergoing termination, she underwent chorionic villus sampling, and the genetic material was sent for the skeletal dysplasia panel, which revealed a pathogenic variant in the EVC2 gene, which is associated with Ellis-Van Creveld syndrome. So now this patient had a genetic diagnosis. In the next pregnancy, however, This patient, what she did was that she came to us at around 12 to 13 weeks and again got her first trimester scan done. Fortunately, in her fourth pregnancy, there was no abnormality seen in the initial first trimester scan. She was not very affording. She did not opt to go for further genetic testing. She just went for an ultrasound follow-up at 18 weeks, which was again normal, and she went on to have a normal child in her fourth pregnancy. Now, Ellis Van Creveld syndrome causes a lot of things which we can detect on ultrasound, like short long bones, post-axial polydactyly, and heart issues like AVST. But you must note that there are certain things, especially the nails and the dental and oral manifestations, which are not evident in ultrasound. And that is why I stress that though ultrasound is a very good tool, but we must understand that its limitations. And so every anomalous fetus, if possible, should be subjected to a detailed postnatal evaluation, because that helps in narrowing the diagnosis a lot. We move to the next case of Mrs. S, a 32-year-old lady who was again a primea gravida with a non-consanguineous marriage and a spontaneous conception. In this pregnancy, she had undergone a combined first trimester screening exam, which was low risk for aneuploidy. The ultrasound exams, that is the NT scan and the mid-trimester anomaly scan, were perfectly normal. However, she came to us at 36 weeks with femur and humerus length less than the first centile and an amniotic fluid index of 22. Now, when we plotted her femur length, as you can see from this growth curves are a very good way of visual representation of growth of a fetus, and one should use them because they help us in understanding as to what is happening to a fetal parameter. And you can appreciate here that initially the femur length was fine in the second trimester, but you can see that somewhere in the later part of the second trimester, and when we have seen her at 36 weeks, the femur length is way below the third centile. So this showed that there was a decrease in bone length. At the same time, if you see her growth curve for the head circumference, what you can appreciate is that initially the head circumference had been going around the 50th centile in the early part of second trimester, but now in the third trimester, the head circumference was above the 95th centile. And how did the baby look on ultrasound? Now, since there was good amount of amniotic fluid around the face of the baby, we could see this peculiar appearance of the face. And you can appreciate here in this sagittal section of the face, this prominent frontal bossing. You can see this prominent forehead. There was this depressed nasal bridge. And if you see this 3D volume rendered image, you can see the typical depressed nasal bridge and what we call as the mid-facial retrusion, along with this frontal bossing. So keeping in mind this typical onset of delayed shortening of long bones, which was not evident in the second trimester, but became evident in the third trimester, and the facial appearance of this fetus, a possibility of achondroplasia was kept. The baby was delivered and tested postnatally, and they found that it had a pathogenic variant in the FGFR3 gene, which is associated with achondroplasia. Now, achondroplasia, one must know that 80% of individuals who are diagnosed with achondroplasia usually have parents who have average stature. So that means the parents usually are not carriers, and what happens is that this mutation appears de novo. In these cases, there's a very low risk of recurrence of this condition. However, if one of the parents is affected by achondroplasia, then since this disease has an autosomal dominant mode of inheritance, there's a 50% risk of pregnancy, risk of recurrence of this condition in every pregnancy. The thing about achondroplasia is that we cannot diagnose this shortening of femur at our routine 18 to 20 weeks scan, because the natural history of the condition is such that the mutation results in the disruption of enchondral ossification of long bones, which becomes evident only in the later part of second or in the third trimester. So it's not possible to make a diagnosis. And normally we follow this dictum that if we see a fetus with a short femur length at 18 weeks, we know that it can at least not be achondroplasia. So that is why this is a diagnosis which is usually made in the later half of pregnancy. And since if we are able to identify a mutation, we can offer prenatal testing in the form of chorionic villus sampling in the first trimester to such a patient in her next pregnancy. Next, we come to a case of Mrs. N.S., a 27-year-old lady who came to us in her second pregnancy. She had one previous child. Her marriage was non-consanguineous, and this was her natural conception. The first baby, however, when she came to us, was a 3-year-old girl who had been born with dorsal edema of feet. So she had subcutaneous swelling on the dorsal aspect of bilateral feet. She was under the care of a plastic surgeon for that dorsal pedal edema, and what she had was a karyotype report, but it was not a karyotype report that we have these days. It was a handwritten karyotype report. There was no image of the chromosomes available. What was written in the report was a suggestion of Mosaic-Turner's syndrome. She had undergone an ultrasound at 1 year of age when this karyotype had been done. And at that time, the ultrasound was reported to have a normal uterus with non-visualization of both ovaries. Now, the lady came to us in her second pregnancy at 22 weeks because this fetus again had bilateral dorsal pedal edema, and she was worried as to whether this fetus had Turner's syndrome. Now, this was the appearance of the feet. This is just a 2D image to show you the thickening of the subcutaneous tissue on the dorsal aspect of the foot. And this was the appearance of the foot in the 3D rendered image. So this was this subcutaneous swelling on the foot. The fetus underwent amniocentesis, and fish and karyotype was done. However, to our surprise, both turned out to be normal. So there was no evidence of Turner's syndrome or Mosaic-Turner's syndrome based on fish and karyotype report. We repeated the ultrasound of the sibling, and when we assessed that 3-year-old girl again, we could actually see normal uterus and normal multifollicular ovaries as well. So probably the ovaries had not been evaluated appropriately at a previous date. Now, since fetal DNA was stored, it was tested further for congenital lymphedema. And actually what was found was that there was a pathogenic variant in this FLT4 gene, which is responsible for a congenital lymphedema, which can manifest prenatally, that is Milroy's disease. And this has an autosomal dominant inheritance pattern. So again, an autosomal dominant inheritance pattern. However, none of the parents were having a phenotype suggestive of this Milroy's. So none of them had dorsal pedal edema, but they had had 2 children with the same condition. So a possibility that maybe they had a germline mosaicism, which means that this mutation is just confined to the gonadal cells and the parents do not manifest, was given. So this case just goes on to show you that one should always be aware of labels. So, one should not accept whatever is written without going into depth of it. The child had been labeled as Mosaic-Turner's, and that was the end of story. But actually, when this child, the 3-year-old girl, was tested, she was also found to be carrying this pathogenic variant in this gene. So one should not just accept a label on a given individual at its face value, but go through the records, go through the reports before making any conclusions. And finally, this last case, which shows how ultrasound sometimes has to work over a period of time to come to certain answers. This was a case of Mrs. B, whom I saw 8 years ago when she was 30 years old. Hers was a non-consanguineous marriage, and she had had 2 prior neonatal losses, both of which were delivered by cesarean section. Now, she was a lady from a very rural background. She did not have much records. What she could tell about, she didn't have any pictures of those children, but what she could tell was that they had abnormal faces, and she compared them, those faces, to those of Jadoo from the movie Koi Mil Gaya. So if you recollect, this was the character in that movie, and that is what she compared the faces to. She had limited records of the second neonate because after birth, that neonate had been taken to a tertiary care hospital in our region. However, it had just survived for a day and then succumbed. The second child had been a 2.8 kg male child with abnormal facies, and it had died due to query respiratory distress. That is all that was written. There was a clinical suspicion of Cruzan syndrome, which is a craniostosis syndrome, which results in premature fusion of sutures and hence abnormal facies, as you can see, like these. And that is why she had probably compared the appearance of the child to that character. However, she carried a report of Sanger sequencing, which had been done for this gene for Cruzen syndrome had been tested, and that had come out to be normal. So she had felt that she had done everything correctly. She had taken the kid to the tertiary care hospital. They had done an expensive genetic test, but it hadn't yielded anything. And so she was quite desperate that this was her last chance probably of conceiving, because the family was not ready to support her, and they, as is the case, sadly, that a woman is usually blamed for any kind of a problem that happens to the fetus. And so she was quite desperate that this child should not have any issue, otherwise my marriage is going to fail. So I did her anomaly scan at 19 weeks. It was normal. I could not see anything. However, because a possibility of craniosynostosis syndrome had been kept by somebody who had seen the child, I told her that craniosynostosis is something, that is premature fusion of sutures, is something which we may not detect so early, and it might become evident later in pregnancy. So we advised a 4-weekly follow-up. Now, she didn't come to us after 4 weeks. She came a little later at 26 weeks. And this is what I saw. At that point of time, I was shocked to see that though the brain looked normal in architecture, there was this extensive band of periventricular white matter calcification seen in both the cerebral hemispheres, which was obviously not there last time. The posterior fossa was more or less normal. What was noticeable now was that the ribs were relatively short, because normally the ribs should occupy 2/3 of the circumference of the chest. Now the ribs were short, and as a result, since the thorax was narrow, the heart looked big, as if it was occupying the entire chest. Even the baby's facies was abnormal. The orbits looked protuberant. If you see this section of the sagittal section of the face, there was mild retraction of the mandible, so mild micrognathia, and the fetus was keeping its mouth persistently open. This was the appearance on 3D volume rendered image. You can see how the eyes were bulging. There was mild retraction of the chin, and the mouth was open. Now, this was quite surprising. Bones, however, were normal at this point of time. The fetal biometry was normal, but I was completely clueless as to what had happened, because this lady did not have any history of fetal infection, nor was the appearance suggestive of a fetal infection, because whenever we see brain calcification, the first thing we worry about is fetal congenital infection. But the entire phenotype, that is the kind of brain calcification, the appearance of the face, normal biometry, was not suggestive of a congenital infection, and it was some syndrome. But at that point of time, we had no idea what it was. Now, an year later, we had another lady, Mrs. A, a 32-year-old lady. In this case, her marriage was consanguineous. She had married her maternal aunt's son. She again came to us in her second pregnancy, and she'd had a prior pregnancy loss, which was again a C-section. The only information that she gave when she was lying down on the couch was that the previous child had abnormal facies. But again, there was no record, no photograph, nothing. And what she came for was for a recurrent facial anomaly at 30 weeks. Now, at this point of time, this fetus had regression of certain growth parameters. Polyhydramnios was there, so there was a lot of fluid around the baby. This baby was much more grotesque looking as compared to the previous one. We could see, again, this proptosis, that is bulging of eyes. The facial profile was markedly abnormal. There was prenasal edema. There was persistent opening of the face. The nasal bridge was depressed. There was mild micrognathia. As you can see, this was the appearance of the face. There was this bulging of the eyes, midfacial retrusion, open mouth, micrognathia. And again, the brain, which was very typical, there was this extensive band of calcification in the brain. As you can see, this is a clip which will show you how intense this calcification was. But still, the brain, the appearance of the brain architecture was totally normal. So there was just extensive calcification, but no damage to the brain tissue. The skull in this case had a clover leaf kind of shape, which was suggestive of craniosynostosis. So there was an element of craniosynostosis in this fetus. And of course, the ribs were short again. As you can appreciate, the thorax was relatively narrow as compared to the abdomen. And so there was thoracic hypoplasia. in this case, I said the femur length was short, but not only was it short, there was this irregular appearance of the long bones. So the femur was not normal. And again, now the impression was the same extensive calcification in the brain, along with very typical facies, but an additional element of craniosynostosis and abnormality in the long bones, which was not seen in the previous fetus. But again, at this point of time, we did not know what it was. We again asked this patient to go for testing when the child was born, but this patient was also lost to follow-up. The previous case, again, at 26 weeks, when we had seen these kind of abnormalities, the lady was totally devastated because she was like that I had done an expensive genetic test. I did the ultrasounds in this pregnancy and I still managed to have this kind of a fetus. So I do not have faith in you. And so she did not come back to us for follow-up, because sometimes it's very important for patients to understand that it's not possible for ultrasound or genetic tests to give you an answer at a given point of time, because unless we have the entire information, we cannot offer it to you. Now, in the year 2020, we came across these two articles which were published successively in the same journal, in which they spoke about this syndrome. And when we went through the paper, we could actually see that these fetuses had the same phenotype as our fetuses, the two which we saw earlier, and this same extensive periventricular calcification. In addition, there were abnormalities in the bones in some of the fetuses. And so we kind of concluded, without having any kind of genetic tests, that those two fetuses could have been having Raine syndrome. Now, what happened 2 years ago on one Sunday afternoon, one of my colleagues from my training institute, Mediscan, she called me up. She's based in Kerala, and she asked me if I had ever seen choroid plexus calcification in a fetus at 20 weeks. Now, we see choroid plexus cysts all the time, but I've never seen choroid plexus calcification even in a fetus with congenital infection so far, and that is what I told her. But I went ahead and I told her that I have seen two cases with very extensive cerebral calcification in later part of pregnancy and a very peculiar facies. So she texted me, can you send me the image of those facies? So the images which I showed you, those 3D rendered images, I sent her this image via WhatsApp, and then she came up with this. So she saw a patient, a 28-year-old lady, third degree consanguineous marriage, who came to her in her second pregnancy. In the first pregnancy, she had undergone a termination for the first pregnancy, because at that point of time, multiple foci of calcification in the choroid plexus had been reported, along with an echogenic intracardiac focus. Now, for this, she had undergone termination. At that point of time, she had not undergone autopsy or any genetic testing. And what she told was that there was this bulging of eyes of the fetus. That was the only information that was available. Now, she had come in her second pregnancy to my colleague, because this time, again, the fetus had a flat nose and micronathia. So this time, because of a facial anomaly, she had been referred to my colleague. Now, what she could see at 20 weeks was that the growth and the amniotic fluid was normal. There was indeed these foci of calcification in both the choroid plexuses. But since I had discussed the case with her, she went back in hindsight and she could see there was actually this rim of periventricular white matter calcification even in this fetus, which was not as remarkable as was seen in older fetuses that I showed you earlier. Also, there was this proptosis, and this was the appearance on 3D rendered image of the third fetus, which also had micronathia. So you can see how similar the facial appearance was, though this was a milder form of what you saw earlier. Now, this time the lady opted for termination of pregnancy, followed by external examination of the abortus. She did not give permission for an autopsy due to religious reasons. And this was again the appearance of the abortus. You can see how the eyeballs were bulging. There was this depressed nasal bridge, mouth open. There was hypertelorism. However, we could send the genetic sample for testing this time. And since based on those two cases, we were thinking in terms of this Raine syndrome, a possibility was suggested. and the genetic result came out as positive for the mutation associated with Raynaud's syndrome. So this is how a long workup and sharing information with each other brought us to a diagnosis after a period of almost 5 years. Now, I hope by the end of this presentation, I've been able to convince you that ultrasound doesn't act in isolation. Ultrasound examination should always be preceded by a detailed history of the patient, because that guides the ultrasound examination. Ultrasound examination should always be guided by a detailed obstetric history. One should always try to store data, whether it is ultrasound images or if you see an anomalous fetus and you cannot subject it to an autopsy, one should always have a detailed documentation of whatever the abnormalities are seen, because they can be helpful later on. Especially in fetuses with skeletal dysplasia, if you cannot subject the fetus to an autopsy, the bare minimum that one can do is get an fetogram, that is a radiograph of the fetus, because even that can provide us some information which can help in later pregnancies. It's important that we work to ultrasound should not restrict ourselves in an anomalous fetus to go through the routine checklist that we do for a low-risk pregnancy. When we are assessing a high-risk pregnancy, we have to look at the fetal phenotype in much more detail. And as I said earlier, the importance of postnatal examination and autopsy cannot be underestimated. Also, whatever we see, either prenatally or postnatally, must be correlated with the genetic tests. Sometimes the genetic test says something while the phenotype doesn't match. So that is also very important. And as in any field of medicine, it's important to be persistent and perseverant, because sometimes it takes time. As I said, it takes years to come to get certain answers. And since science is ever evolving, we have to be updated with the literature so that we get answers to questions which were not solved earlier. And it's very important that whatever information or knowledge that we have, we share with our colleagues, because that helps us in growing. And a sonologist doesn't act in isolation. One always, whenever providing prenatal care, we have to indulge in multidisciplinary dialogue and work in close collaboration with our OB as well as genetic colleagues, and especially in case of anomalies, even with our pediatric colleagues. Thank you.
Dr. Divya, I don't know what to say. I think everybody is equally fascinated like I am. And always we are in the same trance when you speak. So I don't know really. I mean, ye dil mange more types,
Thank you, ma'am.
Like
My
so
privilege, and thank you for the opportunity.
I have a few comments to make, but I would like Varuna to conclude the brilliant talk.
Dr. Divya, this was like not just a, information power-packed, precise, literally power-packed presentation. You kept all of us engaged so well. I mean, in fact, genetics listening to you, it almost feels like, a thriller movie.
It is, ma'am. Ratna ma'am makes it a thriller. I mean, it is a thriller.
So basically, you
must
have to
agree
remain
that we all should be
alert.
cautious while doing
Yes,
our
all
scans.
alert,
We need to
keeping
put
a
more
lot of
brain.
things in mind. And, trying to pick up every piece of information from all ends and collaborating, it only will help us to basically maybe justify our roles as healthcare providers to a lot of these women who are actually, as in your case, those women who are not even do not even have proper access to a lot of good healthcare. So a lot of a very strong history taking and your clinical sense up, and then collaborated with the results in resource poor settings also would be always remain have its own place always. Very nice presentation and very aptly picked up cases to elaborate your viewpoint. I actually can congratulate you for your
Thank you,
effort.
ma'am. Thank you, ma'am. Pleasure is mine. Thank you.
So I wanted to ask Dr. Divya that everything boils down to, after talking to Ratna ma'am, listening about the genetic studies and the tests to be done, to be taken with a pinch of salt. Finally, the patient conceives, She might not have seen a geneticist in the prenatal period. She just comes to you. So everything comes down to phenotype, phenotype, phenotype. You talked so much about phenotype. Now, I remember in our anatomy department as undergraduates and in the forensic department, these two specialty, we had these huge jars with fetuses, right? So the anomalous fetus can be a lifelong learning experience. I had gone to attend a CME of perinatology in JIPMER, Pondicherry, where I was exposed to a huge department wherein they counsel patient for hours and take the patient for autopsy and preserve a few feti. I was wondering if medical colleges and the patients who deliver in government medical colleges, if they could be, motivated to donate that fetus, anomalous fetus for preservation in formalin in a jar that could, serve as an education for months to the training undergraduates and postgraduates. Second question was that you had mentioned about a case with thickened NT detected at 11 weeks. You had strong suspicion. One case turned out to be normal at 16 weeks. The other case, which you saw at 18 weeks, still had a thickened NT and went for termination. Now, that gap between 11 weeks and 18 weeks, Dr. Divya, is so huge. The patient is coming for the combined test at 11 weeks or simply an NT-NB scan. Then you have a gap of 7 weeks before she comes for the anomaly scan at 18 weeks. And you tell her the same finding of thickened NT. So that 7 weeks period, that gap period, she just comes and gets the same finding and undergoes termination at 19 or 20 weeks with a big fetus. So can that gap be reduced?
Ma'am, first question regarding preservation of fetuses. Yes, ma'am, definitely anomalous fetuses should be sent for autopsy. But if they are to be tested for a genetic test, then it's not recommended to send them in formalin. Rather, it's better that they are sent in normal saline, because once the fetus is preserved in formalin, then it's not possible to extract DNA for testing. So
Once
if
DNA is extracted, after that the fetus can be preserved?
yes, then it can be preserved in formalin. Otherwise, that is what is suggested, is that if you haven't been able to preserve DNA, send the fetus in normal saline to a lab which can then extract DNA and then preserve the fetus. Because once you put it in formalin, then at least the DNA part is lost.
So many of the high impact pictures from your presentation were high impact because of the clear pictures and that awesome videos and clips you gave to us. So when we can get so influenced simply by seeing the pictures, imagine an undergraduate or a postgraduate seeing those fetuses preserved in
Yes.
glass cases and being able to see it, for years and years. What do you comment about this gap?
The second point, yes, ma'am, regarding that gap, actually, I think you probably missed it. We saw her at 13 weeks and she underwent CVS at that point of time. We had stored the DNA. So she had undergone a chromosomal microarray at 13 weeks. So chromosomally, the fetus was normal. Because the NFT was thickened markedly in the second trimester, then she underwent testing for single gene disorder, basically. So we tested her for a single gene disorder because chromosomal abnormalities we had ruled out by chromosomal microarray, but still there was a persistent abnormality in the second trimester. So she was tested for a single gene disorder, that is Noonan syndrome at that point of time. So actually, she had gone at 13 weeks after the CVS with the feeling that at least chromosomally the fetus was normal.
So do you think that once we get a thickened NT like this and we order for a CVS for CMA, can we
should
order
also do testing?
Should we do a single?
That is what I told you, ma'am. There are studies which have done whole exome sequencing for isolated thickened NT, and what they have found is that around a 2% yield. So you do a very expensive test, whole exome sequence for isolated thick nuchal translucency, and you'll just have a 2% additional yield. So whether we should offer that at the time of the NT scan or whether we should defer it for the second trimester scan, I think that is something which we need to debate, because it's an expensive test.
But in first world countries, it must be done that way.
I think Ratna ma'am would be in a better position than me to
I
comment
just
on
come in
that.
there.
And your comments, please.
Yeah. I just want to say that the challenge is not in doing the test. We can do the test. We find a lot of challenges in interpretation. And we get a lot of variants of uncertain significance, and we don't know how to deal with them. And because when families see something on a report, they will go up and end up terminating pregnancies where actually the baby does not have a problem. Because we know that over a period of time, 90% of these WOOS variants, as we call them, are not disease causing. They are variations that are present in normal human beings, which is why we all are different and look different. So therefore, conservative testing is important. And I really, for the first time in my life, I so appreciated Dr. Divya putting up there that there are NT values more than 6, 7 before we start thinking of Noonan syndrome, not in small NTs, because the yield of the test is low where there's actually Noonan. And the second thing is that there's no hurry in doing it. In the second trimester, if you get an increased nuchal fold, if you get some other sort of renal abnormality, some other pleural effusion, these are features that suggest a rasopathy. So I think it's very important, not because the test is expensive, and in pregnancy, we want to do a trio exome and not a solo exome. So that makes it even 3 times more expensive, but because we want to interpret it properly. You know, we are not supposed to be, by recommendations and guidelines, reporting a variant of uncertain significance in a prenatal sample. But no lab listens to that. They need to see something on their report. So that becomes very disturbing.
Thank you, ma'am. Thank you, ma'am. There was another case you talked about.
I wanted to congratulate Divya now that I'm unmute on her presentation. It was wonderful, Divya. Thank you so much.
So, ma'am, you can't imagine Dr. Ratna and Dr. Divya together. What a fiery combination this has become.
I never thought I would get a chance.
So-
Thank you, Monica ma'am.
So I'm really honored. And there was another case, Dr. Divya, Ellis-Van Creveld syndrome, where the 4th fetus turned out to be normal. And that patient repeatedly came to you. 3 fetuses she lost, 3 babies or preterm. And the 4th fetus ultimately was normal. So, like, how is it possible? Like, what is the inheritance pattern or?
Yes,
How-
I didn't go into the detail, ma'am. Ellis-Van Creveld has an autosomal recessive pattern of inheritance.
That's right.
So
Yeah.
there's a 25% risk of recurrence in every pregnancy. So there's a 75% chance of having a normal fetus in every pregnancy.
So yeah, and the last point I wanted to make was consanguinity. I was traveling back from Aurangabad recently, and in my first AC compartment, we had that upper and lower berth, that 2 thing. So a student was on the upper berth, and he showed me the picture of his sister's son. He was going for a job interview, and he said, "My sister is married to my mama's son." And that baby was looking slightly, abnormal and whatever. I didn't comment. But consanguinity is there. So as obstetricians, we come across so many families. We talk to so many people. We talk to young girls, adolescents, and dadis, nanis. We talk to menopausal women. We talk to a geriatric population. I think this has to be put forward very strongly. Consanguinity is not something the general population understands the implications. So every opportunity I have, I really, make it a point to nudge gently. So this guy who was traveling with me, I told him that, Shiva, remember, don't do that. Don't marry a cousin. Then I explained him the whole thing. He was a sports student, but he understood. So I think consanguinity is something which is preventable across communities, at least the people we come in touch with. Just a message. Thank you so much, Divya. So any other comments from our audience, from our chairpersons? So thank you, Dr. Divya, for the brilliant talk. And thank you, Ratna ma'am, for the awesome talk. And now I think we go to the much awaited.
Really, Monica, you have both the speakers are excellent. It is mesmerizing talk by them. I really congratulate all of you. I must say all the three, Monica and Dr. Ratna, as always. She's always excellent and never miss to hear. And Divya, you are a rising star. I must say this.
Thank you, ma'am.
So after this, we would like to test our practical knowledge, and we would like to see what our panelists have got to tell us, because Dr. Asha Jain, our moderator, has put forward her questions in advance to the panelists. So the panelists have been given ample time to read, prepare, and answer properly to Asha ma'am. So we proceed with our panel, and over to the coordinators.
Hello, Dr. Shikha.
I think Purva, you can start the panel. She'll join.
Hello. Yeah, thank you everyone for giving me this opportunity. So I would like to introduce our moderator, Dr. Ava Jain ma'am, to this panel, and I would like to introduce her to this session. Please show
I'm
this.
Asha Jain, Dr. Purva. I'm not Abha.
Sorry, ma'am. Dr. Asha Jain, ma'am. So, Dr. Asha Jain, ma'am, is a chairperson, Foods and Drugs in Medico-Surgical Equipments Committee, FOXI. She's currently the director of SMSA Hospital, Raipur, and Cancer Prevention and Relief Society. She's a chairperson for FOXI in the year 25 to 27 and president at Raipur Menopause Society for the year of 24-26. She's an executive member, Chhattisgarh, ISA, and FSM. Her center is recognized by FOXI and for USG and colposcopic training. Ma'am ma'am, I would like to welcome Madam to this webinar. And I would like to welcome our co-moderators, Dr. Monica Singh ma'am and Dr. Purva Badkar in this session. So moving forward to the panelists, I would like to introduce the panelists. So first, our first panelist is Dr. Charu Sharma, and I would like to welcome her to this panel discussion. She is an additional professor, Department of Obs and Gynae in AIIMS Jodhpur, and her special panel is a body for short-term and fetal medicine from AIIMS New Delhi, and she's a past secretary of Rajasthan chapter of SFM in 2024, and she's a co-coordinator for postdoctoral fellowship.
We have to be very short. Shikha, please be very short. Asha ma'am is waiting.
Yeah.
So just stick to 1 or 2 lines for every panelist, please.
Yes. So I would hand over to Dr. Richa to introduce the next panelist.
Hi, so now I am inviting Dr. Chetna Ramani ma'am. She is a consultant gynecologist at Ramakrishna Care Hospital, Raipur, with a special interest in critical obstetrics, contraception, and menopause.
Our next panelist, I would introduce Dr. Deepali Mittal, madam. She's a consultant at Apollo Hospital, Indore, and she's joint secretary in Indian Obs Gynae Society in the year 2024 and 25.
Hi, so next with us is Dr. Divya Yadav, madam. She is associate professor at SN Medical College, Agra, and she has received Dr. C.S. Dawn Award for Best Paper Presentation in 2015 and 2017.
Yeah, next,
please.
So I would like to introduce Dr. Kruti Deliwala, madam. She is an associate professor at Municipal Medical College, SVP Hospital, Ahmedabad, and she has presented many papers in state and national conferences and has been awarded as Yuva FOXI Best Doctor in Yuva FOXI.
So next joining with us is Dr. Monica Pathak, madam. She is senior consultant gynecologist at Sri Sai Sushrita Hospital, Raipur.
Next. I would like to welcome Dr. Pragya Suryavanshi, Madam. She's a senior consultant of gynae at SMS Hospital, Raipur, and she is joint secretary at ISAR, Chhattisgarh chapter. Next.
So next joining with us is Dr. Rachna Agrawal, madam. She is consultant gynecologist at Goyal City Hospital, Agra, and ex-professor at SN Medical College, Agra.
Next. So I would welcome Dr. Richa Gansal, madam. She's a professor and head at Government Medical College, Karnal, and she has many researches, many international and national publications to her credit. Next.
Next slide, please. So next joining with us is Dr. Smita Dhengle, madam. She is a renowned fetal medicine specialist at Bhopal.
Next slide. So I would like to welcome Dr. Supriya Hajela. She's a director and ART specialist in Bhopal. And she has received ISAR Youth Icon Award in the year 2023. Next slide.
So our next panelist is Dr. Surbhi Dubey. She is a fetal medicine specialist at Bhopal.
Next slide. Our next panelist is Dr. Urvashi, madam. She is a professor in Department of Gynae at Sarojini Naidu Medical College, Agra, and she has received the Jagdishwari Mishra Award in AICG in the year of 2024. Next.
I think that is all. No, Vanna madam is there. Yes.
Next with us is Dr. Vandana Agrawal, madam. She is assistant professor at Atal Bihari Vajpayee Institute of Medical Science and Dr. Ram Manohar Lohia Hospital, New Delhi. She is joint secretary AOGD of the session 2024 to 25.
Welcome, Asha ma'am. We can start the panel, madam.
Thank you, Dr. Monica. So, thank you. And, Ratna ma'am is still here and I'm really terrified, but I'm really very happy as well because then whatever queries we have can all be solved. So we have had two scintillating lectures. Ratna ma'am has explained a lot of things and Dr. Divya has given us the practical demonstration. So what we are going to do now is basically the questions that we as gynecologists face. And when the patient is in front of you, what should immediately come to your mind? Even if you are not a practicing genetic person, you're not a practicing fetal medicine person, but you are her obstetrician. How are you going to manage this and what you're going to do after? So we have challenges in genetic diagnosis. They have both been covered very, very comprehensively by Ratna ma'am and Dr. Divya. Our panelists and experts have all been introduced. So now we come, I don't know how many are actually present here because I see a lot of messages that, we are not able to come, we are not able to come. So I have not assigned questions to anyone. Anyone and everyone is free to answer. So, I would like to ask my experts, what is a screening test and what is a diagnostic test? What is the key difference in a screening test and a diagnostic test? And what are the performance differences?
So, madam,
I
screening
would take
test
up this
is what?
question.
Yeah.
Okay,
Can
go
I?
ahead. Go ahead.
Okay, madam. So what is the screening test is that we perform at mass level to screen the condition. What is it? Because sometimes some like thalassemia or at our Chhattisgarh state, there is sickling, there is prevalent. So we screen at mass level, then it is not necessarily 100% like sometimes we are screening it. It is autosomal dominant, recessive. There are many varieties. So for confirmation of diagnosis, we need confirmatory test, that is diagnostic test.
Actually, Dr. Pragya, there are 4 basic parameters. You know, the sensitivity, the specificity, the positive predictive value, and the negative predictive value. Now, these 4 performers, how do they differ in a screening test and a diagnostic test? Smita ma'am, would you like to say something here?
Yes, screening test definitely we apply it to the general population, to each and everybody. So that from that we screen who is a low risk one, who is a high risk one, or
And that is
intermediate
already
one.
there. What I'm asking about these 4 performance criteria.
The sensitivity is that we are truly the one who is affected. Are we going to pick that up? And if the test has come positive, then is the person really being positive for that disease or not? That is the positive predictive value. So anything that any test that we are applying to a population, the test should have that kind of a guarantee, in a simple word, I would say, to pick up that disease. Or if it is not there, then it should be able to tell if it is a negative test, then the test is not there. So a test which is applied to a general population will screen it, and if it has come as positive in screening, then we go over to a diagnostic test which gives us the answer as yes or no. So it gives us 100% answer for it.
I think what Asha madam is trying to ask us is the sensitivity and specificity in screening and diagnostic test. Are you asking?
Yes.
So I think that if we are talking about screening test, then it must have very high level of sensitivity, so that it can catch lot of patients. And if we are talking about diagnostic test, it should be very much specific so that we cannot give wrong answer.
So actually,
I feel that your question was catching.
A screening test is one which has a very high sensitivity and a very high negative predictive value. Right. These both things have to be combined. That if it says no, you don't have the disease, most of the time you should not be having the disease. Okay. So that is a good screening test. And a diagnostic test is one which is not that sensitive, but it is very specific. So if it is applied on a population, it will not work. And it has a high positive predictive value. That means if the test is done and the report is positive, the chances of it being positive are as near 100% as possible. So this is how we decide. And that is why you cannot take a highly specific test as a screening test. Okay. So what are the different screening tests you have? We've already heard about it. So if somebody would just do it, what are the screening tests we have? What are the diagnostic procedures we have?
So for screening, we go ahead with the sonography early, sonography scan for anti-scan, nasal bone and soft marker, all these things, and combined it with the markers, the biochemical markers for fetal anomalies, or if needed, NIPT. So these all are non-invasive things. But for diagnostic test, we need to go for invasive diagnosis like CVS or amniocentesis, so that we can come for the final diagnosis, maybe by using karyotyping or maybe by using microarray, or if needed, a higher exome sequencing kind of thing.
So you can go ahead. One thing is that you would never do another screening test when one screening test is positive. You would go ahead and do a diagnostic test.
Right.
And then what you are going to do will depend what you are suspecting on combination, as Dr. Divya has told us. What are you actually expecting? So whether you're doing a karyotype or a microarray or an exome, clinical exome, whole exome, all that will depend on what you are suspecting. So first thing is to be able to correlate the findings of the test with your ultrasound markers. Dr. Charu, would you like to add something here?
Ma'am, screening, as you have just told, the screening test, we have the first trimester combined screening, we have the quadruple screening, and we have NIPT. So it's a very good point that after we get a negative result by first trimester combined screening, we should never go for a lesser sensitive test like the quadruple screening, because many a times people go for a second screening. So that should not be done.
All right. So we've
I
done
would
that.
like to add something too, ma'am.
Yes, ma'am.
Screening here, though we are discussing just genetics in this webinar, but screening per se does not only include genetics and aneuploidy screening. Screening should include the health of the mother as a
Ma'am, I
whole.
cannot
Like
see
we
you.
should.
Would you just say who's speaking?
Kindly put on the video.
I'm
from-
Dr. Surbi.
Yeah.
I need your video on, please. Otherwise, it's very difficult to interact.
Yes, please.
Hi,
put
I'm
your
Dr.
video.
Surbi.
All panelists who want to speak, please put on your videos. It is basic courtesy to the moderator.
Yes,
My
go ahead,
video.
please, Dr. Surbi.
So I would like to highlight that there are other things which we need to screen on the first visit of the lady, like pre-eclampsia screening, screening for FGR, screening for diabetes, screening for hypertension. There are other things which can be prevalent in the family and in that area, like sickle cell, thalassemia. So all those things are and should be included in screening and not just aneuploidy screening.
I totally agree. And that is why the first trimester ultrasound, even when your NIPT is low risk, needs to still be done.
Yes.
Because not everything is covered by that. So now we proceed to answer question number 2. When do you want to do NIPT as a first choice? And when do you not want to do NIPT as a first choice? A patient is in front of you. When are you going to suggest go ahead and have an NIPT? And when are you going to say, go ahead and let's do a combined screening with ultrasound?
Can I take that too?
Yeah, please go ahead.
So NIPT is a very good screening test because it has a sensitivity nearly about 99%, and it should be offered to those mothers who had a history of aneuploidy in previous pregnancy. Because first, because it is a better test, and second, because the mother is more anxious because she had a bad past obstetric history. Second thing, when a mother comes to you with a positive biochemical screen, but the scan report is normal, so only on the basis of.
Dr. Dr. Surbi, you need to understand the question.
So NIPT in
whatever we know is not what I want. I want here specially a patient has come to you at 9 weeks. Now, when are you going to advise her NIPT? And when are you going to say that, no, you go ahead and have a normal NT scan with first trimester anomaly scan and the extended markers?
So
there is a
NIPT
difference.
can be.
I'm not talking about step 2. I'm talking about when will NIPT be step 1?
So it will be
I
offered
think I
only
want
after
somebody else
gestation.
to answer it.
Gestational age of 11 weeks. After gestational age of 11 weeks.
No, Dr.
I
Richa
think,
Kansal, ma'am, this is an answer I want from you, please.
Hello, ma'am.
Yes,
A very good evening to all. Thank you for posing this question to me. Once I'm talking about NIPT, I think this is a very strong screening test, as you already talked about. Of these, when we are offering such tests, then it should be a patient who is a specific population in which I am expecting that NIPT will contribute to my diagnosis. So somewhere, if I have an age group that is more susceptible, for example, I can have a patient who's more than 35 years of age, or history in which an affected child has been born to that mother. Or they can be a first degree relative who is affected by chromosomal anomaly. In all those patients, I like to go for NIPT straightforward. Like I should not be limited with an ultrasound or a dual marker in order to think about whether I need to go for NIPT or not. So NIPT will be a good choice for me. If I talk about when to bypass it, in such a situation, if I have a strongly, say, affected individual in which I'm suspecting that the baby might be affected, for example, I can have an ultrasound in which, say, more than one soft markers are there. Or I have a case in which a previous affected child is there and there has been a consequence, like the previous speakers
Soft
were talking
markers
about.
are only important at the 20-week scan.
Yes, ma'am.
And you are doing this as a primary screening between 10 to 13 weeks. So
Agreed,
let
ma'am.
us not bring in soft markers here.
Ma'am, if I'm talking about, I have a nuchal thickness and I have a, say, non-ossification of nasal bone. If I'm having both of those two together, if I'm having features in which, say, I have had 2 or 3 children in a mother, and that lady has had recurrence of anomalies that have been occurring, in all those situations, I like that patient should go for CVS or say amniocentesis as
I
planned.
think what here madam is asking, at 9 week she is not having NT and all these things. 9 week she is
Ma'am, 9 to 14 weeks. 9 to 14 weeks is my gap. I have to consider all the cases that are coming up in between.
The question
I
is
would like to
actually
pitch
very,
in
very
over here.
simple. Which patient you will advise directly first go for NIPT?
I
Then
would like
come
to pitch
later.
any high risk, all high risk patients.
Exactly.
No.
That I'm
High risk
willing.
Smita
patients,
ma'am?
ma'am.
Yes,
Ma'am,
Smita
it
ma'am.
I
has to
would
be
like
high
to
risk
say
patient.
something over here.
Yes,
Any
ma'am.
lady who has had a baby with trisomy 21
Right.
proven before, she is a candidate where we can go for for this NIPT, because the sensitivity of 99% or 99 point something, that sensitivity is only for T21. For T18, 13, it is lesser than that. So it works great for T21. So if a lady has had it before in a child and it has been proven, then we go directly for NIPT in that case. If somebody comes to me at 9 to 10 weeks and she is an elderly lady, for that lady also, I would say wait
That
for
becomes
NT
high
scan.
risk.
I'll do a scan and then I will decide whether I go for NIPT, or I decide after the scan ki yes, now this scan is good enough, and then I say go NIPT. So I will wait for the scan, but only T21 proven before, I'll say straight away go for NIPT. That's the only thing I would wait for. Nothing other than that.
If there is a structural anomaly, you would proceed
Then
that.
not at all. Structural
Then you
anomaly is not at all NIPT. It is an invasive testing.
Invasive test.
Okay.
That
And
is
plus, ma'am,
invasive.
if there is a previous history of a monogenic disorder, then all the more we are going for an invasive test. There is no point of doing an NIPT at that for that.
That's what I'm
particular
saying.
test.
So wait for NT scan and wait for other histories and then take a decision, because it is such an expensive test. Wait, and then there's no harm waiting for 2 weeks and taking a good decision.
Okay.
That's what, na,
So
ma'am.
now we
We
go
have to consider the whole gestational age in
Yes.
which
And
we are
what's the
talking
hurry?
about.
What's the hurry about?
What's the
Isn't
hurry?
it? Let
That's
the
what.
baby
No, ma'am.
form.
So,
See,
do
that's
you
why I
understand?
got you a fetus at 9 weeks.
Ma'am,
That's
you
why I
have
got
got
you
the
a
fetus
fetus
at
at
9.
9 weeks.
I'll wait for
Because
the baby
we
to grow.
will proceed. We have 20 questions. We are going to cover everything. Okay. So now you have NIPT, but in which cases do you directly go for CVS or amniocentesis? You don't want to do any biochemical marker. You're going ahead directly with CVS or amniocentesis. Any of my fetal medicine people can answer this.
Like
if there is a structural
Dr.
abnormality.
Divya was talking, all structural anomaly, like she was showing the cases. Such kind of cases must go directly for the, all structural anomaly cases must go directly for the invasive test.
Your NIPT is positive, you should go in for CVS if you warrant an early result. Or if you want, you can wait for an amnio if you want to do it after 15 weeks. If your NIPT is positive, you have to do a confirmatory test, be it CVS or amnio.
So it can also be when both parents are sickle cell carriers or thalassemia
carriers.
So you would want to go ahead and do a CVS without doing NIPT or anything, because your target is something else. Your target is not aneuploidy at that point of time. Okay?
Right.
So we are doing a good job, right? सब पढ़ के आए एकदम अच्छे से, और मैडम लोग ने पढ़ा भी बहुत अच्छे से दिया है.
क्लास अभी बहुत अच्छे हुए मैडम. Both the sessions were very good.
Yeah. So now this is the question that is in our heads. and then we call the lab wala ki bhai kya karna hai isme. How do you choose between microarray, karyotype, and exome?
Can I take this question, ma'am?
Yes, ma'am. Charu, ma'am, please go ahead.
Ma'am, I always explain this question to my PGs that if we have an almirah with a set of 24 books, and if we take out one book, so that is the change in the number. So if we want to detect an aneuploidy, whether there is a loss of a chromosome or there is an addition of chromosome, so to detect the aneuploidies, we go for karyotyping. From that particular book, if one page is deleted, like on that chromosome, one part is deleted or one part is added, to detect those micro deletions and duplications, we need to go for a chromosomal microarray. So if there is a structural abnormality, we would like to go for a chromosomal microarray. And suppose if from that particular book, one word is missing. So to detect that, we have to see all the genes on that chromosomes. So to detect the single gene disorder, we have to go for a prenatal exome sequencing.
I see Dr. Divya is still here. Dr. Divya, can you just put on your video for a minute? I want to ask you a basic question. Are there any specific markers that suggest a balanced translocation?
Dr. Divya, are you there?
She
ma'am,
is
I'm
there.
there.
Yes, ma'am. Yes,
See,
Dr. Divya.
on your ultrasound, is there something specific that would suggest a balanced translocation?
Ma'am, short of a,
Yeah.
ma'am, there is a balanced translocation is something which is diagnosed on karyotype, ma'am.
Agreed. I know that. So I'm just asking you, when would you order that?
I mean, we usually do it a karyotype of the parents to look for balanced translocation when we get a conceptuous with an unbalanced translocation. So if we
Agreed.
have a
But
fetus,
what are the findings in the fetus that you are likely to get if they have an unbalanced
and there
translocation?
can be an unexplained fetal demise.
Okay.
There can be an
And even if
unexplained.
there is a balanced translocation, how would you actually suspect it? That is what I'm asking.
Ma'am, usually in fetuses who are in patients who have got recurrent pregnancy losses, when we test the abortus and the abortus comes out to have some issues, that is when we test the parents for a balanced translocation.
Okay. So
Balanced translocation is something that we test for based on a bad obstetric history rather than something on ultrasound.
all right. All right. So thank you so much for those inputs because I needed to know that.
Yes, ma'am.
So the answer here, when are you going to prescribe a microarray plus minus karyotype? When you're going to advise exome? When there's a single major anomaly, then microarray plus karyotype. So you can detect aneuploidy and CNVs. More than 2 major anomalies or skeletal brain problems, you go for exome. And suspicion of balanced translocation, go for karyotype. Okay. So the decision is made during pre-test counseling, balancing the resolution, turnaround cost, and parental values, whether they actually want it or not. If there are more than 2 unexplained pregnancy losses, what is the test that you're going to advise?
A couple karyotype.
Should be the first choice.
That will be the first choice. And if the couple is ready for the karyotype, the genetic testing of the product of conception, then in that case, a chromosomal microarray for the products of conception. Because in products of conception, we do not have the live cells. So karyotype will be difficult because we need to have a culture. So we can go for a chromosomal microarray. And nowadays, we are also having the karyotype by NGS. So karyotype can be done by sequencing on the products of conception also.
Is it more expensive?
It is less expensive than the chromosomal microarray.
Okay.
And the turnaround time is also less.
Okay.
So, Charu madam, you said that for karyotyping you need live cells.
Yeah.
But here
Yeah.
with karyotype with NGS, you can do even on
Yeah,
products of
because
conception.
we are not culturing the by NGS, we are not culturing the cells.
Right, right. So the
For
accuracy,
culture, we need live cells.
accuracy remains the same.
Yeah.
Right.
And the additional point is that we can also get the deletions and micro deletions, which we are getting in the CMA.
See, all of us are clinicians as well. How important is it if you have a single gene defect, something like that on a missed abortion case, you sent for NGS or whatever. How relevant is it to her next pregnancy? Because many patients will say, no, we don't want it. Right.
So that counseling is very important because we have to tell them that these single gene disorders, these are Mendelian disorders. So they can be autosomal dominant, they can be autosomal recessive or the X-linked recessive. So we have to tell that if it is an autosomal recessive, in the next pregnancy, there are 25% chances of having the affected baby and 75% chances of having a normal baby. If it's an autosomal dominant, then 50% chances of having a next affected baby. And in X-linked, we can tell them that only the males will be affected and so on. So by this, they can have an informed choice whether they want to go for a pregnancy, whether they want to go for an IVF and the other testings prior to IVF.
Okay. Dr. Supriya, now this question comes to you. How do you think we can embed carrier screening into routine antenatal care?
Thank you, ma'am. I think in routine antenatal care, we need to look a little bit preconceptionally also. And there also we need to embed few points. Like if the patient, if you're suspecting thalassemia, we should be doing, like ma'am has taught us HB electrophoresis to know any gene disorders. Once the patient has come to you at 12 weeks, you can go in for if you are suspecting single gene disorder for cystic fibrosis or spinal muscular dystrophies, you can test her, and only if she's positive, you can test for a husband also, whether they both are carriers, and explain it to the patient what are the percentages of getting it transmitted to the fetus. And I think
basically here we from Chhattisgarh always like to add sickling. So sickling, thalassemia, any combination of the two, because some patients will have sickle cell as well as thalassemia minor. That is also seen in our place. So you would do whenever somebody comes for preconception counseling or at the first antenatal visit, these basic tests need to be done. And this we all need to incorporate. The blood group, the RH typing, HPLC for her sickle cell and thalassemia status. Cystic fibrosis is not so common here, but yes, muscular atrophy skeletal-muscular atrophies are common. I have patients where entire families have the same problem. They come to you at the age of 15, 20, they are not able to walk, not able to move. And another thing that I've seen is Ratna ma'am has emphasized so much on history. Patients don't truthfully tell you the history unless something goes wrong. That is my experience. How many would you agree? Yes, Dr. Richa.
They hide history.
Ma'am, it's absolutely correct
On third
impression that you
visit,
have given.
sometime third visit, we got the history, which was
The
hidden.
history at
Usually when
times is
something
missing.
has gone wrong, then
Hmm.
they will tell you, yeah, ऐसा भी हुआ था, वैसा भी हुआ था, family में है.
With that, I'll add, ma'am, कई बार तो number of बच्चास भी add नहीं होते. So when you come to know, you start with Gravida 3 or Gravida 4 and you actually end up to Gravida 10 or 11, finding out that there have been so many mishaps prior to it.
You
So
know,
that
ma'am, there is another community in our area that only counts the sons. So you ask them how many kids you have. If they have sons, they'll tell the number. If they have girls, they don't count them at all. They'll not tell you how many girls they've had. You're thinking she's a primey. No, she's not. She has probably 7 girls, but they are not counted as children. So that is one thing. And if something goes wrong, you will find a lot of people saying, yes, this has happened in our family, but not before. So we have to really understand very well. So now this is one part for us. What must pre and post test counseling include? What are the factors that we need to include here?
Can I take the question?
Yes, please.
So before prescribing any test, we must know that what are the pros and cons. What this test is going to tell you. Suppose this test is it gets failed. What is the chances that we need another test, reconfirmatory? Or suppose we advise very rarely, in hardly 2 cases I have advised exome sequencing, and some aberrant results comes, then we need to explain them what these things which is not very important, how to deal with these things. So we have to
ma'am explained this very well. That
so very
patients
well.
see anything normal, they do an abortion. Finish.
Right. So
We are dealing with lives, and that is why pre-counseling is extremely important.
So they should be very well pre-counseled so that they will not take any hard step later on.
So what are the different things that you want to cover in this counseling? Dr. Shikha, would you take this? Dr. Shikha Gupta, please. You're muted.
Madam Shikha is my coordinator. Shikha, have you studied? You can take the question if you have studied.
Okay, so I'll take Vandana ma'am. Dr. Vandana Agrawal ma'am,
Yes,
if you
ma'am.
would take this.
Yes, ma'am. Thank you, ma'am. Ma'am, so we need to tell the couple about the risks associated with the procedure. What is the cost? What is the turnaround time? What are the results that we are expecting? We have to tell them that it's not 100%, that if the result comes as okay, then the fetus and the baby are going to be all right. They have to know this. There is something called uncertain significance also. Variants may be available in the reports. So proper pre and post procedure counseling is extremely important.
Don't you think that, there is a small risk of an abortion as well?
Correct. Yes, ma'am. If we
That
talk
has
of
to be
numbers,
included.
yes, ma'am.
Be
It's
informed.
0.5% in singletons, ma'am. And in the case of multiple pregnancy,
That depends on the experience of the operator.
yes, ma'am. Correct, ma'am. Right, ma'am. In experience hands, if we talk about, then it's said to be
But
0.5%.
people got that experience by doing it for the first time someday.
True.
Right? So you cannot say that it has a 0.5 risk.
True.
Somebody who's done 100, maybe 0.5%. But everybody is starting sometime.
Correct.
So we need to have a realistic estimation of what is happening in our centers. What is the loss in our center? And that realistic risk is what we need to give. And there has to be emotional support and written information as per ICMR. You need to have a documentation of that explanation.
Yes.
When those of us who are FMF members certified, there it will not give the calculation unless you have said that the counseling has been done. It doesn't give you a calculation at all. So that counseling is a primitive primary part. Somebody already has an affected child. Okay. Now, what are the constituents of that counseling?
I think someone has already discussed that what is the when it is dominant gene, then it is the chance of 50%.
It may be a non-recurrent thing. Let us start with that. Why do we have to jump to X and Y?
Right.
Right. It could be a non-recurrent disorder.
Sporadic. Right.
Sporadic disorder.
Sporadic disorder.
So, Dr. Surbhi, I think you can shed more light here.
Yes, ma'am. So first of all, history is very important as to what was affecting the previous child. Is it inheritable? Is it de novo? Was the parental evaluation done in the preconception period? And at what gestation the patient is coming to us for counseling? Secondly, if it is an autosomal recessive kind of disorder, we need to tell them that there is only 25% chance of baby being born with the disease if both the parents are carrier. 50% chance that the baby will be a carrier, and 25% that the baby may have a normal chromosomal pattern. Then if it is an autosomal dominant type of
I think you need to go over that again because you've made a mistake. Please go over that
autosomal
again.
recessive, both the parents are carrier, then chance of occurring in this pregnancy or in every pregnancy, it will be 25% having an affected child, 25% having a normal child, and 50% that the baby may have a carrier as similar to the parents. Then if it is an autosomal dominant type of a disease, then every pregnancy will have a 50% chance of baby being diseased. If it is an X-linked disorder, then X-linked disorders usually affect the male individual, and every male will have a 50% probability of having this disease. If it is any other single gene disorder, we will have to offer targeted sequencing for the same mutation in current pregnancy after parental evaluation, or we can even offer a trioclinical exome analysis in the current pregnancy.
Thank you so much.
But
So
ma'am,
now
these things
you've done
become
an NT scan. Yes, please. Somebody was saying something.
yeah.
Yes,
Ma'am,
Charu
these things become easier when a child is previously affected and is evaluated. But most in the practical situations, we get the child who is affected and is not evaluated, and the patient
Yes.
has come during pregnancy. So that
So
becomes
we
a
will,
challenge.
Ma'am, many a time the first child is affected, is evaluated, and nothing concrete is there.
Yeah.
You know, they've done everything and they have no concrete answer because all the sensitivity of all the results, if you add up everything, it was still not more than 40%.
Yes.
yes,
So there are
that
60%
was.
who will never have a diagnosis.
Yes, and it was similarly shown in Dr. Divya's slide that Raynaud syndrome, which was not known previously, could not be evaluated.
So
But if
now
the child
there
is
is
not, if the child is not evaluated and the person has come in pregnancy, so it is always better that we evaluate that child first and then go for any genetic testing in the current pregnancy.
That I agree with completely, ma'am. So now there is a patient who has an increased NT, more than 3.5 mm. Karyotype is normal. Now, how are you going to manage this? You've done a karyotype, right? Now this karyotype is normal. How are you going to evaluate further? And increased NT is the only finding you have.
I think we should follow up the patient, close follow up to the patient. And we can go ahead for the anomaly scan and the baby to check the cardiac status of baby and other the soft markers. So if everything is okay, we can go ahead. Or if there is some problem occurs, meanwhile, we can always opt for the diagnostic test.
We can offer fetal echocardiography as well in the
That is cardiac checkup.
to rule out any cardiac anomalies.
Ma'am, even the family history is also important. We should find out कि इससे पहले कोई affected रहा है, symptom कुछ ऐसे syndromes रहे हैं या कोई cardiovascular या कोई और anomalies family में run करी हैं. That is also equally important, and I think that should be paid attention as well.
Yeah. So now you have not found anything else. Do you directly want to go ahead and have a microarray, or you're going to wait and do an anomaly scan?
I preferably will wait to go for to see whether any soft marker is changing, it is still persisting, then I will proceed for the invasive test. I am little conservative for directly going.
To go for microarray.
Even me, ma'am.
What did you say?
I will like to proceed for microarray, ma'am.
See,
Is
an
the person can afford?
isolated finding
Yes.
can later, you might miss cardiac anomalies in a
Yes.
small heart.
Yes.
So you need to evaluate the heart later. And then there is Noonan syndrome.
Noonan syndrome, yes.
So you can do a FISH for Noonan's if you wish. Right. If you find something else in the future, if you see the profile is not really normal, you can go ahead and do that. So this was a chart that Dr. Divya had shown beautifully. So there are soft markers. How do you triage them? Which ones do you think are something to worry about and which do you think are okay, no problem?
Depends
the ecogenic heart, ecogenic focus in the heart. Is it important?
No. Single, if it is only
Doesn't
isolated
need
finding
anything
is not of
much.
much importance.
Not much of importance.
Okay, so you're not doing that.
No.
Basically, there is
Multiple
that
we do.
genetic sonogram calculator, which gives you the risk. And it
Likelihood ratio is important.
likelihood ratio. And the beauty about likelihood ratio is that it takes the positive findings that it also calculates with the negative findings.
Negative findings.
So all together give you a list. So if there is an ecogenic bowel, what would you test for?
Cystic fibrosis.
Cystic fibrosis and
Torch infections.
torch.
Infections. If there is mild ventriculomegaly, you count up to 10 is normal, right? Now you have 10.5 or 11. What will you do?
Follow up
Serial sonography, ma'am, follow-up sonography.
of the patient.
Ma'am, don't you think you need to actually see whether the section has been correctly taken?
Yeah,
Definitely.
definitely.
That is really very important because people cut sections anywhere. When you see the reports, so whether the section is correct is the first thing you need to see. And then you follow up with a neurosonography and do the soft markers and do the genetic sonogram. You will always be alert, that is for sure. But the first thing we as gynecologists need to understand is, please look at the films and see that the measurement and the section is correct. Now, what is this VUS, variant of uncertain significance? You've done a whole exome and you have 10 lists that you have seen all these varieties, which are VUS. How are you going to manage this case?
Counseling.
Counseling.
Now, what counseling? What is the content of your counseling?
Well, there are no pathogenicity associated with the
Known pathogenicity till now.
associated with the variant, but we need to follow it up, and we cannot say directly that it is. We have to follow it up, and we have to take a proper consent, and we have to,
Go ahead.
counseling should be done regarding.
I think Dr. Pragya said the most important sentence. What she said was that we don't know what it means till now.
Yes.
We may get an association in the future because as Ratna ma'am had shown, that now we know the function of more than 7,000 genes. There are 20,000 in all. Now, the remaining 13,000 something is wrong. We don't know what's happening. But it's constantly evolving. What we know as unknown significance today may become significant tomorrow.
Right.
So
And
we
it's
need to
very-
keep up with the research.
And it's very important that we see the phenotype. For what phenotype we have done that. So we have to match the phenotype with what VUS has come. And then we have to do the parental segregation also. So because if the VUS has come in the heterozygous form and the same variant is present in the parents and they are normal, then we can easily counsel them that it is a variant of uncertain significance. The baby will not be affected. So parental
this we have to-
segregation is
We
very
cannot say it
important.
with confidence.
We have to
have
order
to-
exome sequence of parents also in
Yes.
that case.
Agreed.
So it's a
But
big
what the thing is, you should not abort a fetus on this ground.
Yes.
Don't abort a fetus. Don't take irreversible decisions based on a VUS report. I would not do what you said, Dr. Charu. I would never say the baby is going to be normal.
Yes.
I always say that a baby
We
is
don't know.
normal can only be proved at 25 years of age.
Yeah.
You know,
Actually, ma'am, this is the
so
most
many things are coming up. Genes are responsible for so many things. We are extremely deficient in knowledge. So
Yeah.
how do I say normal?
Yeah, definitely. The baby will be
But
just like
muscular
the
atrophy is
parents.
sometimes present late.
And probably phenotypically, we can say the baby might be normal.
But madam, this actually is the most controversial area. बहुत difficult होता है to make the couple understand कि this is not meaning anything.
Counseling
ये
is
challenge
very
है हमारी counseling का
challenging.
इसमें.
Counseling and documentation also, madam.
बिल्कुल बिल्कुल मैम and we cannot say कि this fetus can come out as normal
Yes.
or not normal.
Yes.
We can only say or
We-
we can say that whatever we know we can predict that what is coming out.
I think the third line in this answer, provide a clear written report emphasizing uncertainty
Uncertainty.
and a follow-up plan. So in that follow-up plan, what are you going to look for? What made you do that exome in the first place? There must have been something, right? Whatever it was, that has to be followed up. You don't do an exome on every patient. So you've done it means you found something. So that something needs to be followed up, which may have nothing to do with this VUS. Now, somebody has some incidental finding from prenatal exome. You were not looking for something. You just got a report that we have this pathological variant. Now, what are you going to do?
So this should be the part of pre-test counseling always. Whenever we are doing an exome
Ma'am,
sequencing.
I'm just asking you, you have that report. What have you counseled that patient? What are you going to counsel that patient? The pathological variant you find today had nothing to do with what you had advised. जो आपको दिखा उससे ये कोई connected नहीं है. But you still have that variant. So what are you going to explain? What is the content of your counseling?
So I think what is the significance of that that particular diagnosis we got, particular information we got, we need to tell them and involve counselor as a team in our genetic counselor. So what it is going to affect the baby, whether it is of insignificance or some significance, we need to counsel and involve as a team counselor. So together we can reach to the final that we can go ahead, baby, and make their mind preparation that it may turn after delivery, it may turn something, or there are chances, whatever we can say 2%.
Basically, actionable adult onset conditions have to be reported. If it is actionable.
Breast cancers or
only those things.
Those things have to be reported. Rest
Otherwise.
involve the counselor. Now you have an ultrasound that is showing something, a thick NT maybe, a little bit of ascites, but the genetic result, everything is normal. Now what you're going to do?
Can I take
Follow-ups.
Follow-up, detailed target scan, early target scan, serial follow-up is very important in this case.
Ma'am, why not think about that there might be some problem we need to discuss with our colleagues as well. Since we are dealing with such a situation, we might have other issues also. So to evaluate it completely, a pedigree is required. The history again is important. And we need to understand whatever findings we are getting, do we need to put an emphasis onto it? So what I do personally, if I find some findings and I'm not able to reach to a conclusion, I involve one or the other person who can help me out in this. So a team approach is something that should be thought about with these cases. ये मुझे लगता है मैम बाद में मिस करने से अच्छा ये है कि अभी इंटरवीन करो.
So one thing is involve a friend, involve a genetic person, have a radiology opinion. If ultrasound is abnormal and genetics is normal, get the genetic scan repeated, get the mid-trimester anomaly scan repeated by some other expert. Okay. Still, if it's abnormal, and you can go ahead with an exome, right? And if the genetics is abnormal and ultrasound is normal, what are you going to do? Genetics says something is there, but your ultrasound is totally normal.
So
And
it
there
will
can
depend
be
upon what
evolving anomalies.
normality is being detected in this genetics.
Then there can be, ma'am,
The counseling and follow-up plan will be depending.
So
The follow-up plan will be
follow-up
dependent
has to
upon
be
the disease which
So
is
one
being
by one.
diagnosed.
First Dr. Surbhi, then Dr. Richa, then Dr. Charu.
So, ma'am, if the genetics is abnormal, we first need to look into the report, what disease is being talked about, and then we need to make a follow-up plan as to how we will counsel and the parents and follow up the fetus.
Okay. Dr. Richa?
Ma'am, once we are checking up, I like to add to Dr. Surbhi's that if the method that we have used in order to pick up that abnormality has to be thought upon, the limitations, what exactly they are. And we have to understand that at times a sample that we are taking might be contaminated. Like we might be dealing with a twin gestation, or we might be dealing with mosaicism, or we have picked up, say, on CVS, we might get isolated placental say mosaicism that might be there, or normal cell rest might be there, that might not be affecting the fetus. So the test, in what context it has been done, what tissue has been taken, how the test has been done, what are the limitations, these also form a part of this genetics abnormal as we have gotten. So to what extent we are dealing with. So that's from my side.
There is that term of variable expressivity. Can somebody explain that? What is variable expressivity?
And basically in autosomal dominant disorders, generally it is not so that every individual will have the similar presentation. So they can have presentation at different ages, at different gestation. So there can be some evolving anomalies. So basically it is in the autosomal dominant condition, the variable expressivity.
Anybody wants to add something here? Anybody? Supposing you have mosaic results, how are you going to interpret them?
I want to add one point that suppose it is from the CVS, chorionic villus, then it may be because it is placental tissue. So there are chances of some false positive. So in that case, we can think about that and repeat workup, which is absent with the amniocentesis.
So if you detect a mosaic or suspect a mosaic, you can go ahead and do an amniocentesis. Okay. A fetus may carry 2 lines. And in that case, what you would do? Wait and watch. You would wait and watch, right? Which organ is affected by the mosaic? These are very, very rare conditions. And it doesn't cause a miscarriage. Miscarriage is only because of the procedure we are doing. Now, ART. A lot of ART experts are here. Dr. Monica, who has started this program, is an ART person. What is the role of genetic testing in ART pregnancies?
Ma'am, basically in ART, we would like to give a successful pregnancy to the couple who has come to us. So involving this, we would like to do a genetic testing on the embryo, either for aneuploidies or single gene testing could be done to know which embryo is normal, and then we would transfer the normal embryo to increase our successful pregnancy rate. So we would like to make a good decision making, and then we would like to do it, because if the patient conceives, infertile patients are obviously very anxious. They conceive and they end up in missed abortion. They are all the more anxious.
You have done the PGT.
Madam, here I want to add That's I am giving just an example of my patient. Both husband wife were thalassemia minor. I told them there is 25% risk of in the baby. So first baby we did amniocentesis, it became positive, major, and they aborted. Now we advised him that PGM, so trophectoderm biopsy, good embryo is blasted, but still I advise them it's okay that it is PGM, it's diagnosed, but you still need the further workup like amniocentesis to reconfirm, because once it is done, PGM is not 100% we are sure. We need to cross-check it by later, because patients, both the couple are carrier status, and that is very high risk status. So we need to reconfirm it with CVS or amnio in such cases.
Thank you. Can I add something?
Yes,
Can I add
please.
something? In ART pregnancies, this is considered PGT-A and PGT-M are both considered as adjuvant therapies. So adjuvant therapies have been brought under the scanner of ESHRE guidelines published in Human Reproduction in 2023, and they categorically state that though implantation rates do improve following PGT-A, but the overall live birth rate and your clinical pregnancy rate does not change. So this is just considered as an adjuvant, but all having said that, it is very important in cases of recurrent pregnancy losses or a history of aneuploidy, like Supriya said, you can easily nowadays take that embryo to blastocyst stage, take a cell for biopsy, wait, freeze the blastocyst, and in a subsequent cycle, you can select that embryo and transfer it in a thaw cycle.
So for that, you have this third line. Confined placental mosaicism after trophectoderm biopsy.
Trophectoderm biopsy, right. There are chances.
There are chances of that. And if you are using donor egg or sperm, you need to have all details of the person from whom that sperm or egg has come. Because you don't know. If that is not proper, then your whole genetic counseling thing goes haywire.
Madam, can I ask you one question which is little away from the topic? But since you mentioned a lot of sickling in Chhattisgarh, there is a case which has been put in the State Surrogacy Board of Madhya Pradesh, which is a controversial case. The commissioning couple, the woman, is a known case of sickle cell anemia. She has suffered from sickling crisis twice.
So she is SS.
Yes, ma'am. And the bilateral tibial head necrosis, and hip also is like the femoral head necrosis. So now, without having undergone any cycle of IVF or any procedure, is she a fit candidate for taking a surrogate?
Of course, she's a fit candidate, because see, a sickle cell patient is a very, very high risk patient, likely to suffer from all kinds of crises. What you are mentioning are bony crises, but she is a fit candidate for going for lung crisis, which will finish her off.
The important thing is she reached to this age is very big thing. Sickle cell major girl. There are menstrual problem with them. They have recurrent blood transfusion history like thalassemia major patient. She reached that age and she is still safe. It is big thing. So she's good candidate.
SS, madam, without SS, they don't have sickling crisis?
AS will not have a crisis. It is only SS who has a crisis. So now, if there is a patient, we are not a low resource setting. We are a middle resource setting, but for a country which has so much of population, where would you advise expanded carrier screening?
I think, ma'am, the health problems should take over as to how much is a burden and which particular disease is important in that community. That ways we can think about, putting up in a low resource setting, because our output should be good. If we are putting up a test.
Like for Chhattisgarh, sickle cell disease, thalassemia, any combination of those two. Because sickle cell, even if they are a carrier, AS, they still have anemia. If they have sickle cell with thalassemia, they have a low hemoglobin and a high ferritin level, and you don't know how to actually treat that anemia. So these are cases wherever there is prevalence. So the first line is most important. You need to know what is the prevalence and accordingly offer the highest sensitivity test. Now, this NGS, how has it changed prenatal diagnosis? Next generation sequencing, how has it changed prenatal diagnosis?
It has increased the diagnostic yield in many conditions. Like initially, we used to think that cerebral palsy is only because of the difficult labor or the prolonged labor. But nowadays, we are evaluating the baby. So we think of other genetic conditions, and NGS has brought about a lot of single gene disorders or the monogenic disorders. And similarly, in the autism spectrum disorder, the intellectual disability. So these cases where the chromosomal microarray is normal, the NGS has increased the diagnostic yield. And similarly, non-immune hydrops fetalis. We get a lot of patients where the karyotype is normal, or if we have done the CMA, that is normal, and we are doing exome sequencing, the NGS. So we are getting a lot of rasopathies and other single gene disorders. So it has definitely.
What is the limitation? What is the limitation?
Ma'am, the limitation is the cost, the availability of the incidental findings, the VUS. So all these are the limitations.
So you need a really good counseling infrastructure. Because if you don't do counseling, you're losing all those babies. When do you want to do a microarray and when you want to do a karyotype? What are the pros and cons?
So this chart is very clear that microarray, there is a comparative to karyotype, there is a wider window, we have, like in karyotype, we see the balanced translocation and we see what is the, jisko in Hindi we can see the mota cheeze. We see what is the, like, there is a trisomy or monosomy, such kind of things. And with microarray, we can go in deep inside the regarding genetic details.
So basically, the bottom line is choose microarray for structural anomalies, and karyotype remains adequate for isolated aneuploidy risk. When you're looking only for aneuploidies, you go ahead and do a karyotype. Otherwise, if there is any structural anomaly, choose a microarray. That is the bottom line, which gives you a 6% extra yield. And then if the patient has aborted, in that case, you can always store the DNA. All those VUS, whether we can get something out of them in the future. So what are the medical legal implications and consent challenges?
All diseases cannot be diagnosed by genetics probably, and that we can miss writing legally in our consents. We cannot diagnose each and everything.
So there are templates in ICMR and RCOG, and we should use them translating into our own local languages, visual aids, vernacular leaflets to take the consent. This is the basic thing. Either you miss a diagnosis or you overdiagnose, or there is VUS. These are the places where you get stuck. So ICMR and RCOG both have. And we as in Bharat, we need to go with the ICMR is what I feel. So now we come to the last thing. And here I would like an opinion from all the panelists. How to integrate genetics into routine obstetrics in resource-limited settings.
And we should have a chart made for each and every antenatal patient, like we have a card made. These particular set of tests have to be done for each and every antenatal patient. Like we can offer them at least a double marker if the patient is affordable, or not, at least a sonography. We have to tell them the sensitivity of each and every test, and if they are affordable, we can step up in a likewise manner. So at least a minimum set of tests required for any pregnant patient entering a clinic should be there. And that similar thing should be taught to your assistant, that if a patient has come, you need first, if any patient who is booked outside, check whether these things have been done for the patient. If not, what else can be offered to the patient instead of that test which was missed previously. So
We personally feel we should be obstetricians should be trained, because since we are not trained in genetics, so eyes don't see which the mind doesn't know. So all of us should be trained in basic genetics. That is my take.
I
So we'll be able
specifically
to guide.
joined this panel
Ma'am, awareness.
just to learn genetics.
Yes.
Awareness, ma'am. Awareness not only for the doctors, for patients and the would-be patients as well. So awareness in the society, awareness in that these things are available. These are the things that can be detected early, because anywhere pregnancy, if it is taken with the view that a healthy child should be there at the end. So with that thing in mind, I feel sensitization and awareness should be spread throughout the society, because even if we advise at times the patients, they do not accept the test. So awareness at the level of the society and our fraternity both is required. From my side, I feel this is.
And prevalence of the condition in that area is also important. All tests cannot be offered to all.
Right.
Agreed. And
I think, ma'am, the obstetrician, they should not just read the impression of the ultrasound report. They should see the entire ultrasound report, and as well as they should know how to interpret the genetic reports. Because just seeing a genetic report where it is written pathogenic variant seen, so they have to see whether it is in the homozygous condition or it's in a heterozygous condition. Because many a times the patients have been referred to us for termination because they have just circled that point that pathogenic variant is written. But they have to see whether it is a heterozygous or a homozygous in cases of autosomal recessive conditions. So the entire report should be read, not only just the impression.
I would like to add that the first line is the most important, because 1/7 of the world's children are born here. So at least 1/7 of the world's abnormalities are here. So if we can have a national registry for anomalies and what is the genetic result in those anomalies, that 7,000 would very quickly climb to 15,000 is what I feel. Because we have the maximum number of babies and we have the maximum number of anomalies as well. 3 to 5% babies are abnormal. So with this, I had shared this with you that all the answers have come from the ACOG committee opinion, ACMG career screening practice resources, ISWOG 11 to 14 week ultrasound guidelines, RCOG Green Top guidelines, which were reviewed in 2024, and ICMR National Ethical Guidelines 2017. I had shared these with you. So now, before I end the session, I would like to have a take-home message from all the experts and panelists, and thank you all for being with me this evening. Thank you. Thank you so much.
Thank you, madam. Thank you enlightening us for to allow us to read such a very important and brainstorming these questions.
So basically, I want one take-home message from each one present here on the screen. Just because you're a coordinator, you don't give a message, doesn't work. You're still listening, Dr. Shikha. So Vanna ma'am, I can see you first on my screen. So
Yes,
would
ma'am.
you just one take-home message from you?
I think we should have more of these webinars, amalgamating with such stalwarts, gaining of knowledge. It's wonderful. We should have more of these webinars. This is the take-home message.
Varuna ma'am?
Ma'am, the take-home message that I am taking tonight with me is that even if we are general obstetric practitioners, We should have in-depth knowledge about anything that is happening to the fetuses, even at their genetic levels, and be able to interpret the reports as someone rightly pointed out. Should know how to look at the pictures of the scans, should know how to read the genetic reports and everything.
Thank you so much, Varna ma'am. Sarla ma'am, आप सीनियर हैं, आप कुछ कह दें आशीर्वाद का.
I congratulate Synergy Club and taking initiation, meaningful dialogues, and we should, the old obstetrician should go for depth knowledge
मैडम
in
आप
antenatal.
मैडम आप ओल्ड नहीं है, लोगों ने अभी आपको डांस करते नहीं देखा.
I didn't say old, I said senior.
नहीं, madam called herself old. You are the youngest.
We should go in depth knowledge.
Charu ma'am.
Ma'am, as an obstetrician, we all must know how to make a pedigree, because with that, we will not miss the things which the parents are hiding from us. Because when we pinpoint how many children, how many brothers and sisters, what is the relationship, so we get to know many things which in a normal situation we may miss.
Okay. Pragya?
I would like to say, if we get some report, we should not take the decision in hurry. We should give proper time, reassess, rethink, and then decide.
Dr. Richa?
Ma'am, I'd like to say that the emphasis is equally there on communication. What we know is our ability, but if we are not able to communicate it rightly to the patient, then the whole purpose is lost. So a good communication skill is required, and we need to pay attention to that.
Surbhi?
Ma'am, consent is the most important. Any test can be advised, but pre-test and post-test counseling plays the major role.
Dr. Supriya?
I think what I learned is exome, a greater mark, then microarray, then greater mark, and then karyotype. So first karyotype, if it doesn't detect microarray, then exome. I didn't know that. I mean, at least I was not aware that exome is the best. I was thinking microarray is the best. So I think after reading your articles, I got to know that exome is the best, and it has a better sensitivity rate even than microarrays. Obviously, everything has its own limitation, but then I'll be able to counsel better now for which patient we need to do. And yes, we don't have to do whole genome sequencing. We are just going to read the exomes. We don't have to read the intron part of these. So whole exome sequencing, not whole genome sequencing.
Dr. Richa?
Hi, ma'am. I have learned in this webinar that don't panic. Don't panic by seeing increase NT. Don't panic by seeing soft markers. We have to move ahead in a very calibrated way.
That is, I think, the crux of it all. That we panic and we make our patient panic. And that ends the life. Dr. Deepali?
I have learned before prescribing a test, I should have an in-depth knowledge of a test so that I'll be able to counsel my patients pre and post better.
Thank you. Now I come to you, Dr. Shikha.
Yes, ma'am. Certainly, ma'am. Genetic counseling is very important for the patient because it improves the outcome. And if the patient is having any history, then we can, after listening to this webinar, I can, as an obstetrician, I can counsel my patient better and offer better tests.
Thank you. So, Dr. Monica, I come to you at the end before I hand over the mic to you.
Thank you, ma'am. My message is that when in COVID time, I wanted to know about genetics and I did not find enough interactive webinars. Webinars were just starting that time. So I thought I'll create these webinars. So this is the third genetics webinar we are doing. And such a nice panel has been done for the first time with so many participants. And the most beautiful thing was that Asha ma'am said, मोनिका मैं ये सब कुछ नहीं करने वाली, पहले मुझे क्वेश्चंस दो. So she scolds me like my elder sister, Mujhe nahi karna. First you do some work. So I had to collect all the girls, collect all the questions. And madam, I must confess, we used a lot of AI for it. So we forwarded those questions to madam and she was very happy. And so this all started. So my achievement is that I have been able to conduct these academic sessions. As far as my work is concerned, now I'm very clear-headed when to do NIPT, when to do a combined test. Triple test is a strict no, quad sometimes, definite indications for invasive tests. And of course, my ultrasound has to become better every day. When I go in front of my ultrasound machine, I pray for a second because this machine has opened my eyes to a whole new dimension. It is my biggest teacher, my machine.
What did you learn today?
I learned that, madam, learn to refine your ultrasound every day. मैम जेनेटिक्स तो आप लोग पढ़ाते रहोगे, हमें तो अच्छी सोनोग्राफी करनी है so that we don't miss what we see.
So, thank you, my dear panelists. Thank you for bearing with me for 1 full hour. I'm really very grateful. Thank you so much.
Thank you.
Thank you.
Thank you, ma'am.
Your questions and answers were totally photo taking. So I have taken a lot of screenshots. And for anyone who wants to revise and see how they have answered to Asha ma'am's questions, please subscribe to our YouTube channel and you can access these videos anytime. You can pass them on to any student you want. Thank you, Asha ma'am. You are permanently there on Synergy.
Thank you.
Thank you. Thank you to all my coordinators. Thank you, Dr. Vishal, the most studious person in the group and the most quiet. Madam, आपने इससे message नहीं लिया विशाल से.
I can always correct myself. Vishal ji, बताइए.
He is Dr. Vishal,
Thank you,
the
ma'am.
medical advisor at Intas. Vishal, आप बताइए कुछ.
Madam, basically, I'm medical advisor in Intas Pharmaceuticals, and basically by profession, I'm a gynecologist, practiced for 20 years, and I joined as a full-time medical advisor looking after infertility segment, IVF segment in Intas Pharmaceuticals.
No. What did you hear in our webinar today that you can think is a takeaway?
Madam, take home is first is go for NT at a specific time before around 11 weeks with a specialist. And as you told, indication of NIPT, history of previous genetic disorder is there, abnormal NT is there, something like that, then go for NIPT. Don't go for NIPT unnecessary.
Thank you so much. Thank you so much. So, over to the organizers to end this session.
So thank you everyone for wholehearted participation. For a full, we have sat here for 3 hours and 33 minutes. So thank you so much for participation, for encouragement, for loving the program so much. I totally love you, Asha ma'am, for giving so much time and knowledge. And I'm going to trouble you again and again and again. So thank you so much, Intas. Till we meet again, we have picture abhi baki hai. We have genetics part 2, which is slated for 30th of May. Please wait for the next announcement. Bye-bye. Good night. Take care.
Thank you, ma'am.
Bye, ma'am.